and India Health Action Trust, and he was also involved in several projects in India, Africa, and Caribbean. He has vast experience in this field and has published over 100 publications. Now, his biodata with me is very huge and large. I have tried to pick up some salient features very quickly, and without taking more time, can I request you, sir, to please give your oration.
Thank you so much, sir. It's indeed an honor to be here amongst you. First and foremost, congratulations and many thanks to the entire team of National Academy of Medical Sciences, the President, the Secretary, and the organizing committee for honoring the specialists in a specific subject matter areas and giving us an opportunity, giving us a platform to share some of our learnings that we've had in our areas of expertise. And congratulations to all my fellow speakers. It's a great honor to be sharing this platform with each of you. And my colleagues and friends who are in person and many who are watching this program online, greetings to all of you. And today my topic for this prestigious oration in the area of maternal and child health is focusing on how do we achieve quality and equity in the area of maternal and neonatal health, and how do we exploit the on-site mentoring within the health systems to be able to achieve the sustainable development goals that we're all chasing, which are due in about 8 years from now. The overview of the presentation as well as the to achieve in this 9 to 10 minute oration is to review the progress that India has made in the area of maternal and child mortality vis-a-vis the proposed number of deaths are happening in the facilities. Since the advent of National Health Mission 2005, there's a great thrust to shift the deliveries from homes to institutions. Despite the progress we have made from 43% in 2004, we have reached up to 85%. Yet, the deaths in the facilities are rampant. Somehow goes to say that the quality of care within the facilities needs to be relooked. If we review the progress in child health, again from 83 per 1,000 live births in 2000, we have come down to 42. And if we maintain this rate, we will certainly achieve SDG target for child health, which is about 25 per 1,000 live births. Likewise, neonatal mortality rate, which was 38 per 1,000 live births in 2000. We have reached up to 23.5. It has been slower in this parameter compared to child mortality. And if we continue at this rate, we will not be able to achieve the SDG target for neonatal mortality rate, which is 12. Again, if you look at India, some of the red maps that you see within the districts and states, these are the districts which are lagging behind. And it's out 246 districts will not reach SDG goal for child mortality rate, and 430 of the again, the same on-site mentoring in Ethiopia and India, we took it to not only facilities and community, but health systems as well. There, if you look at the last row, what was less than 1% population coverage of KMC went up to more than 60%. In most of the states, it's between 55 to 60. In some countries, it went up to 80% as well. So this on-site mentoring can help diagnose the root cause issues and be able to support mentor in a very positive, and even in health systems, government facilities, we could see that they are open and they can change through these on-site mentoring approaches. So keeping these experiences, dear friends and colleagues, what I would like to summarize key lessons is the program science methodology can provide tools and methods to understand the inequities and address the inequities. Also, it can help us identify the critical solutions that can have population impact. The implementation research methodology can help us understand how we can solve the difficult challenges like kangaroo mother care that we just discussed. And thirdly, the on-site mentoring to PSCs and first referral units improved functionality as well as quality of emergency care. These are precisely the gaps we are discussing earlier on, but we have best practices, interventions to address these gaps. So what are critical strategic priorities for India at this stage? In next 8 years, if you have to accomplish SDG goals both nationally and at sub-nationally at district level, one is we need to scale up program science and implementation research capacities at district and state level. Likewise, on-site mentoring can be established at the level of districts, not just in few states, but across the country is something that we can discuss. And that's where we clearly see the role of medical colleges, nursing colleges at a district level, working hand in hand with district health and family welfare to be able to jointly take ownership of the population and be able to make impact at a population level. So ultimately, to be able to implement all the three, what is required is a So what are some of the simple things that we can do to be able to establish a mentoring system and a culture? One is each state, can we identify a nodal agency with high-level research capacity, program science capacity, which can provide technical assistance and mentoring to state health and family welfare system. Like at the district level, can we recognize the local medical and nursing college or some of the professional bodies to be able to support district? Often we see the health and family, medical education, they are not working in team. But is there a way we can leverage to be able to clarify the roles, have a very formal engagement, and jointly take ownership of the entire population, rather than just pointing fingers at each other, and at the end, the communities are the ones who are the losers. This is the final message that I want to convey through this forum. If we can really establish an on-site mentoring as a culture, as a system at a national, sub-national levels, to be able to step up program science capacities, implementation research capacities, and mentoring, technical mentoring to the facilities with a focus on emergency obstetric and neonatal care, I think we can certainly accomplish SDG goals by 2030, not only at national level, but state and sub-national level as well. These are some of the references. I would like to acknowledge, I can't take few names, but we learned a lot from the communities, and thanks to the collaborators, the University of Manitoba, the KHPT, IAT, St. John's, very important, our collaborators, governments, and donors who were really were able to be responsible for achieving this at this stage. With that, I come to the end of my oration. Thank you so much for this opportunity. I'll be happy to take a question or two.
Thank you, Dr. Krishnamurthy, for a very nice presentation. Now I will request Dr. O.P. Kharbanda to present the certificate citation to Dr. Krishnamurthy, please.
Thank you.
As you know, this award is a citation and a cash award of 5,000 rupees. And the gold medal is also there, but that will be given by the chief guest, the function which we have at 6 o'clock. So please be with us.
we come to the second oration, which is the Colonel Sangam Lal Memorial Oration. This oration was instituted in 1979 to perpetuate the memory of Colonel Lal and is to be delivered by a renowned surgeon in recognition of his or her clinical and lab-based research in all aspects of surgical sciences with discernible impact on evidence-based surgical practice. So today we have an eminent surgeon, Dr. Sanjeev Kumar Gupta, who actually is the professor of surgery at the Institute of Medical Sciences in the Banaras Hindu University in Varanasi. He's very well published with over 125 publications in peer-reviewed journals. He's received numerous awards and orations, most notable amongst them being the Commonwealth Fellowship in 2006, the Professor Krishnamurti Oration from ASI in 2010, and the Udupu Endowment Lecture, again of the ASI in 2020. He's also an eminent Senior Surgical Teacher Award winner from the state of UP, again from ASI. So I must compliment him that he's done yeoman work both in the field of surgery and teaching. And he's going to talk to us on a very important topic today, which is the diabetic foot epidemic in India, a surgeon's perspective. All yours, Dr. Sanjeev.
Thank you, chairpersons. Good afternoon, the members of the Council of the National Academy, distinguished guests, ladies and gentlemen. It is a pleasure and a privilege to deliver the Colonel Sangamlal Memorial Oration for the year 2021-22, and I thank the Council for bestowing this privilege upon me. The topic of my oration is the diabetic foot epidemic in India, a surgeon's perspective. I bring greetings from IMS BHU. As we all know, diabetes is a problem which is increasing by leaps and bounds year on year, and the International Diabetic Federation in its atlas in 2019 mentioned that 463 million people between the ages of 20 to 79 years are living with diabetes. And this prevalence has doubled in the last 4 decades. So much so that 11.3% of the deaths are due to diabetes, and regretfully, half of these occur in people below 60 years of age. In the year 2019, there were 4.2 million deaths because of diabetes and its complications, meaning thereby a death every 8 seconds. Unfortunately, 80% of the people with diabetes live in low and middle income countries. And diabetic foot and lower limb complications affect 40 to 60 million people globally. The healthcare expenditure for diabetes and its complications accounts for 10% of the global health expenditure, 1/3 of which is taken up for the care of diabetic foot. As far as the Indian scenario is concerned, India has 77 million diabetics, second only to China. Of these, 15 to 20% diabetics will develop a foot ulcer during their lifetime, and 1 of 5 will require an amputation. So much so that 85% of non-traumatic lower limb amputations are because of diabetes. These account for 35% of hospital admissions, and the mortality ranges from nearly 40% to 70%. This was a review article we published way back in 2012 highlighting the dismal scenario of diabetes in our country. Now, as we all know, I'll just quickly skip through this slide. There are essentially polyneuropathy and peripheral arterial disease, which are implicated in the causation of diabetic foot ulcers, on which superadded is the foot infection. Now, it is important to know what are the risk factors for ulceration in diabetic patients. Given the huge population of diabetes, we should be able to identify persons who are at risk of developing foot ulcers. And one of them is duration of diabetes more than 10 years. Male sex is predisposed to developing foot ulcers, probably because of the fact they're doing more outdoor work. Poor glycemic control, other systemic complications like cardiovascular or renal complications of diabetes, and certain metabolic factors like hyperlipidemia, obesity, smoking. a previous history of ulcer or amputation is a very important risk factor because half the patients who have undergone amputation will come back for another amputation within the next 5-10 years. In a study which we carried out for risk factors in diabetics in northern India, we found that our population in the age more than 50 years of age, with poor glycemic control, smoking, they were all predisposed to diabetic foot ulcers. And though the diabetes was more common in the urban background, the foot ulcers are more common in people from the rural background. Now again, as I said, risk stratification is very important in identifying the patients who are likely to develop foot ulcers. And there has been a consensus guideline on defining the risk categories, which range from 0 to 3. And as you can see, the highest risk category is those who have a previous history of ulcer or amputation. And these are the patients who should be followed every 2 to 3 months in a diabetic clinic. However, if an ulcer has developed, what are the management goals? The first and foremost, obviously, is to get the diabetic foot ulcers to heal. And once they heal, the second aim is to prevent a recurrence. As a corollary to this, it will prevent amputations. If at all amputations are necessary, then our aim should be to limit the amputations so that the limb is not lost. So limb salvage procedures with limited amputations. One of the reasons for development of foot ulcers is deformity, so these deformities should be corrected in time, either surgically or by modifying the footwear. The ischemia, if it is present, has to be taken care of, and as I mentioned repeatedly, glycemic control is important because many of these patients have poorly controlled diabetes. There are various standard of care practices for diabetic foot ulcers, which have a strong recommendation. There are 1 or 2 which do not have a very strong recommendation, but nonetheless are practiced very widely. One of the strong recommendations is debridement. We'll talk about it subsequently. The choice of dressings, offloading of the wound, a vascular assessment is required in patients in whom the peripheral pulses are feeble or absent, or who have signs of lower limb ischemia. And this will include a clinical examination and a simple measurement of the ankle brachial pressure index. Infection control, as I said, is one of the key determinants. Infection is a key determinant for progression of the ulcer, which progresses to initially to a limb-threatening infection and subsequently to a life-threatening infection if the infection is not controlled. Glycemic control goes hand in hand, and we must optimize the blood sugar levels for improving the wound healing. What is very important and should be repeatedly highlighted is the benefit of multidisciplinary care. This is one of the key factors which will make a difference in the management of diabetic foot ulcers and the long-term outcomes. So what is debridement? It is the removal of the dead and necrotic tissue, which decreases, lowers the bacterial count. It improves angiogenesis and granulation tissue formation, stimulates production of local growth factors, and it also facilitates wound drainage and thereby reduces wound pressure. All of these combine to hasten the healing of diabetic foot ulcers. There are various types of debridement, surgical, mechanical, autolytic, enzymatic, and biological. I'm not going into the details other than saying that surgical debridement is the best form of debridement. It is the most cost-effective, does not need very sophisticated instruments, and is very widely practiced. The only problem is that some of these patients, you have to be cautious while debriding so that the bleeding is not there. That has to be taken care of. And you have to explain that initially there may be an increase in the size of the wound after debridement. These are 2 illustrative cases which show the benefit of debridement. And as you can see, over a period of 2 months after debridement, which has to be done repeatedly, and the appropriate wound care, the wound on the plantar, the dorsal aspect of the sole has almost healed. This is another case who has a very big ulcer on the plantar aspect, and this also healed by debridement and serial debridements and appropriate wound care. Coming to the dressing, which dressing is appropriate? Again, there are a wide variety of dressings which are available, and the very fact that so many dressings are available means that none of them is perfect. The aim of the dressing is that we should keep the wound moist and control the exudate. If we take care of these two factors, the wound will heal. And therefore, any dressing which absorbs the exudates and keeps the wound moist is a good dressing. And on that count, there are a couple of randomized controlled trials which say that hydrocolloids and hydrogels are the best. However, cost is a factor which precludes their use, particularly in low resource settings as ours. So generally we use low adherence dressings. Iodine preparations tend to discolor the skin, and there is some evidence that they disturb the granulation tissue formation, but nonetheless they are being used fairly widely. Offloading is another important modality of treatment for which there is evidence, and essentially offloading means distribution of the pressures on the pressure points, particularly on neuropathic ulcers on the plantar aspect of the sole, because of the foot deformity, as the patient walks, the shear stresses aggravate the ulcer and prevent wound healing. And therefore, offloading is one of the important pillars for management of plantar ulcers in patients with diabetic neuropathy. The gold standard is the total contact cast. The problem with that, it is a non-removable cast, and therefore it cannot be used in patients with peripheral arterial disease or with grossly infected wounds which require repeated dressings. There are certain surgical offloading techniques, but they are not very widely practiced. Now coming to wound infection, which is again one of the very important factors. Our aim should be to minimize and control the wound infection so that the foot ulcer heals. And again, they have been graded. It is a combination. The clinical signs are very important. If there are no clinical signs of infection, it is grade 1. If there are superficial tissue lesion with at least 2 of the following signs, then it is a mild infection: local warmth, erythema less than 2 centimeters, and a purulent discharge. If the erythema is more than 2 centimeters and the ulcer has penetrated into the deeper tissues below the skin and subcutaneous tissues, then it is grade 3 or moderate infection. And then there are some patients who will have features of osteomyelitis, abscesses, and features of systemic inflammatory response syndrome, which are grade 4 or severe infections. And this assessment is important. It dictates both the choice of the antibiotics and the route of administration. Coming to wound culture, should we culture all patients with diabetic foot ulcers? The answer is no. Only patients with clinical signs of infection should be cultured. And another important point in culture is that we should not take superficial wound swabs for culture, but we should take the deep tissue biopsy or the debrided tissue for culture, because there is a poor concordance between the superficial cultures and the deep wound cultures. In a study in which we carried out and published, the concordance was less than 10% between the superficial wound swabs and the deep tissue biopsy cultures. Quantitative cultures may help in differentiating between colonization and infection, but they are expensive and technically more demanding. Culture for anaerobic organisms are also technically difficult. Most of the severe infections will have some degree of anaerobic infections. In the study to which I alluded, we could detect anaerobic organisms in only 1/4 of patients. So this is the study which I was alluding to about the clinical microbiological characteristics of diabetic foot infections. Coming to the antibiotic therapy, there is a tendency on our part to treat diabetic foot ulcers with antibiotics, which is incorrect because it leads to development of antibiotic resistance. So it is inappropriate use. No antibiotic should be prescribed in clinically uninfected wounds. There is a very strong temptation on our part as clinicians to use antibiotics. Mild to moderate infections, they are usually monomicrobial and they can be managed by oral antibiotics. And the duration of the treatment is generally 1 to 2 weeks. Severe infections, however, are polymicrobial. The gram-negative organisms predominate along with the anaerobic organisms, and they have to be treated by broad-spectrum antibiotic therapy, preferably parenteral, which can be started on an empiric basis till the culture reports are available, and then the spectrum should be narrowed. However, along with antibiotics, appropriate wound care is essential. The definitive antibiotic therapy should be based on culture results as well as the response to the empiric regimen. The route of therapy, as I said, is based on the severity of the infection. There is also a very strong tendency on our part to prescribe topical antibiotics. The jury is out on that. There is no consensus, and generally they are not prescribed. There is no point in giving topical antibiotics. Another point which is important is the antibiotic should be continued only till the infection settles down or resolves, not till the wound has healed. The wound healing will take much more time after the infection is controlled. And again, the patients often press that the wound has not yet healed, why are you stopping antibiotics? But we have to explain to them that no, antibiotics are no longer required for you, and it will heal otherwise. Coming to the multidisciplinary care, this is one facet which is very, very important. We started a weekly diabetic complication clinic in 2004, and our team included a general surgeon, an ophthalmologist, a plastic surgeon, endocrinologist, and it really worked wonders in the management of the patients coming to our hospital with diabetic foot ulcers. Because before this clinic started, they were moving from pillar to post, going from department to department. They would come to surgery, we would refer them to endocrinology, they would refer them back to us, and so on and so forth. We analyzed our first 1,500 cases. The male preponderance was very marked, 3:1. The male-female ratio, age was more than 55 years. The average duration of diabetes was 5 years. There was poor glycemic control as evidenced by the glycosylated hemoglobin levels. 1/3 of our patients had peripheral vascular disease, and 2/3 of our patients had diabetic nephropathy. What happened with the onset of the multidisciplinary care was that the mean time for ulcer healing reduced to 12.3 weeks, and very significantly, the amputation rate, which was around 22% before this multidisciplinary clinic was set up, dropped down to 7.6%. So this was one of the most singular achievements of setting up a multidisciplinary care, which was very satisfying to us. There are a plethora of adjuvant treatments which have been discussed from time to time, which have been used in various trials. For example, negative pressure wound therapy or vacuum-assisted closure, oxygen therapy, either topical or hyperbaric oxygen, cell-based products like Apligraft and Dermagraft for cover of the wound, certain acellular products. Human growth factors have been very widely used. The fibroblast growth factor, the epidermal growth factor, the vascular endothelial growth factor, and the platelet-derived growth factors are some of them. People have also used autologous platelet-rich plasma and stem cells. We are currently undertaking a randomized controlled trial using autologous platelet-rich plasma for healing in non-infected wounds with development of a granulation tissue. Our endpoint is the time to wound healing. So coming to the negative pressure wound therapy, we have used it. It is the benefit of using a vacuum-assisted closure is that it decreases the number of dressing changes that are required. It absorbs the exudates and hastens the wound healing. There are studies that it stimulates granulation tissue and shrinks the wound, brings the epithelial edges closer. There are certain caveats for its use. One of them is there should be sufficient blood supply for ulcer healing, which is by measurement of toe pressure should be more than 30 millimeters of mercury, and the transcutaneous oxygen pressure should be more than 50 millimeters of mercury. There must be no significant wound infection, because in the presence of wound infection, the wound infection will not be cleared if we use vacuum-assisted closure, and it does not replace wound debridement and measures to improve circulation. As far as the other adjuvant treatments are concerned, they're all in the setting of clinical trials. They are not a standard of care. Of the human growth factors, only platelet-derived growth factor has been approved by the US FDA. There are conflicting results in multiple trials, and they still need more extensive studies before they come into the armamentarium for treating diabetic foot ulcers. So to conclude, ladies and gentlemen, diabetic foot ulceration is a preventable disease. We should be able to prevent diabetic foot ulcers, and that should be our goal, our mission, to decrease the diabetic foot ulcer development. Education and screening of patients at risk of diabetic foot complications is important. We have so many diabetic patients, 77 million, and only 15 to 20% will develop a diabetic foot ulcer. So which of these 77 million will develop a foot ulcer is important to identify. It is important to educate the patients, the importance of footwear, regular annual examination of the foot, and the correct use of footwear is very important. Aggressive multidisciplinary management is essential for treating and preventing ulcers and lowering the number of amputations. So if we set up multidisciplinary teams, it will not only hasten the wound healing, it will prevent amputations, and it will decrease the severity of amputations. As I said, limb salvage procedure should be practiced. If at all it becomes essential to amputate, and limited amputations should be carried out rather than major amputations. Newer therapies are still evolving and are at best adjuncts to standard treatment. So we cannot go on for the newer therapies for the simple reason that they're very expensive. In a country like ours, we may not be able to use them, and their benefits are unclear as of date. So they are at best an adjunct to the regular treatment, the conventional wound care, which is very important. I would like to acknowledge my colleagues on the multidisciplinary team, and thank you very much for your attention.
Thank you, Dr. Gupta, for that very nice talk. We are the diabetic capital of the world. And I think the emphasis on prevention is so important. Our endocrinologists always say, diabetics should take as good care of their feet as they do of their face. And that's so important, because you end up losing one. So to have the risk groups identified and the glycemic control with the multidisciplinary approach are the three doable deliverables here. Thank you very much for a wonderful talk. Thank you.
Thank you, Dr. Gupta. Now I will request Lieutenant General Velu Nair to honor the orator, please. Our next speaker is online, so I will request our computer people to please show the projection. Sir, please introduce.
The next oration is Dr. Sridhar Sharma oration. This oration there is somebody speaking in the background. Yeah. Yeah, Dr. Sridhar Sharma oration. This oration is instituted by Dr. Sridhar Sharma, a senior NAMS fellow and emeritus professor in the specialty of psychiatry and an eminent medical educationist in the year 2018 for a work in the field of medical education and human behavior. The oration is awarded to an eminent medical educationist and public health specialist who is a leader in any field of medicine and a fellow of NAMS with minimum 5 years standing. I am very glad to introduce the orator, Dr. Prakash B. Behre, former Vice Chancellor, D.Y. Patil University, Kolhapur, Maharashtra, former Director, Research and Development, DMIMS, Deemed University, Wardha. He is MD, Psychiatry from PGI Chandigarh. He is former Head of Unit of UNESCO Chair. He has many achievements and laurels to his credit, but I will not be able to read all. It is being displayed on the screen. Significant among them are Dr. B.C. Roy National Award for work on farmers' suicide in Maharashtra, N.N. Day Oration Award, and several others. He is a visiting professor, University of Chester, UK, adjunct faculty, Georgia Southern University, USA. And his important research projects have been funded by ICMR, World Health Organization, DST, Bill and Melinda Gates Foundation, and Harvard, USA. So I will not like to stand between you and the orator. So I welcome and request Dr. Prakash B. Behre to please deliver Dr. Shridhar Sharma oration.
Thank you, Chairman. Is my slides visible now? Can you see my slides?
Yes, sir, we can see. Thank you.
Perfect. I'll start now. Thank you, Chairman, for giving this opportunity. And I'm thankful to Academy, National Academy, for bestowing this Dr. Shridhar Sharma Oration Award to me. And Dr. Shridhar Sharma happens to very closely associated me since 1978. And I was working in Wardha. Wardha is a small place. Sevagram is the village where Mahatma Gandhi Ashram is there, Vinova Bhave Ashram is there. And I worked for about 1.5 decades. I'll just present my finding. And my email ID is given here. If anybody wants to have any clarification or anything, any help, they can contact me. And few of my colleagues from England, they are attending this, oration. One of them is Dr. Uzu, who is a medical director. So I'm thankful to her. So I start my oration. My topic is farmer suicide in Wardha district of Vidarbha region of Maharashtra, challenges and future direction. And this is the area which is very difficult to work and very painful to work. This is the University Datta Meghe Institute of Medical Sciences where I am working. And there is a Jawaharlal Nehru Medical College is the name of the college. I will cover my area from introduction, magnitude of the problem, in difficulties and problem and suicide in Wardha district, the causes, climate change and suicide. This is the burning topic nowadays. Loan and suicide, future direction, and conclusion. These are my areas where I am working. If you open any of the newspaper, you will see some or other news about the suicide in general, but specifically there are many news items related to farmer suicide, like you see, Times of India, farmer suicide, again farmer suicide, farmer suicide. The number may vary in different districts or different states, but it is there. It is all over the world. Now the question is, prevalence of farmer suicide really high? If you see the national suicide rate, which is 10.6 per 100,000 population, this is the national suicide rate, including farmer suicide. This includes all the suicide. If you see Maharashtra, it is 14.2. 14.2 is definitely higher. Telangana is 27.7 and Chhattisgarh 27.7. These are still much higher. So these are the higher suicide rate, is a general suicide rate. So there are chances that there may be farmer suicide. We do not know. This data doesn't say how many farmers committed suicide. Now, this is new data of 2020 where total farmer suicide were around 5,600. And again, here the Maharashtra in the top. In the Maharashtra, it is around 2,500. That comes to 46% of the share of the total farmer suicide. Karnataka 19, Andhra Pradesh only 1%, Telangana 8.35%, Madhya Pradesh 4.2%. So this is the percentage share of the farmer suicide, and this is latest data available in 2020. Over 17,000 farmers in India committed suicide between 18 and 20. That is 2 years' time. And this was presented in Lok Sabha. It was informed in Lok Sabha on Tuesday, February 2022. So again, this is latest data. This is the map of India, and the highest suicide rate is in Maharashtra, Telangana, Chhattisgarh, Madhya Pradesh. I don't know why Odisha, Bihar, it is very less, whether it is less reported or do not know, like Bihar, 0.5, Odisha 9.7. So we need more work in this particular area. Center for Disease Control and Prevention, they told that the farmers are 1.5 times more likely to die from suicide than the general population. So farmer suicide is definitely higher than the general population. And in 2015, the National Crime Record Bureau, we got the proper data on the farmer suicide. We do not have the proper data before 2015. But again, we got some data in 2020. And in between, there is no data of farmer suicide in National Crime Record Bureau. For every one suicide by a businessman, there were 1.44 suicide in the farm sector. It means there is a one suicide in by a businessman, then there is 1.5 times higher suicide in farming sector. But in 2016 and 17, it is reversed. Farmer suicide has come down. Now, surprisingly, in 2015, we got a very good data by Government of India, National Crime Record Bureau. The first time they have defined who are farmers and who are cultivators, because these are interchangeable names. Like the farmers and cultivators are properly defined. They said that farmers are those whose farming is a profession and cultivation his own land or cultivate lease land with or without agricultural laborer. This is the definition. And agricultural laborers, again, they have defined that agricultural laborers are those, these are the primarily work in farming sector. Main source of income is from agricultural labor activities. So this is quite interesting that now farmers, cultivators, agricultural laborers are defined. Because if you are laborer working in the farm, taking on lease, and you are not having a proper crop, you will not get the compensation. So 12,600 persons involved in the farming sector committed suicide. This is quite interesting data. And out of these, 8,000 were farmers and cultivators, around 4,600 were agricultural laborers. It means that 9.4% of the total suicides victims were of farming sector. This is data of 2015. This is the National Crime Record Bureau latest data 2020. Uh, they have covered some farming suicide, but the best data available is 2015. The number of farmers who committed suicide dropped from around 5,600 in 2020 to 5,000, uh, around 6,000 in 2019. So it is dropped from 19 to 20. There are around 2,500 farmers ended their lives in 11 months in 2021. That is last year in Maharashtra. This is by RTI report. So there is definitely much higher suicide rate in Maharashtra. And Maharashtra is a bit concerned about it. This is the data of 2015, although it is a old data, but in 2015 we got a very proper data. So out of 8,007 farmers who committed suicide, around 3,000 were in Maharashtra. That comes to 38% of the sales. So this is very, very high in Maharashtra. That is why I started work around 2004. And it is almost 1.5 decade of the work. Again, Telangana 17%, 7% Madhya Pradesh, and Andhra Pradesh 6.4. Again, National Crime Record Bureau, in 12 years time, 1995 to 2006, there are around 2 lakh farmers committed suicide at the average rate of 16,000 farmers committing suicide every year. Surprisingly, every 7th suicide in the country is committed by farmers, and every 5th farmer suicide committed in India had occurred in Maharashtra. So what is interesting that every 7th suicide due to any reason committed is farmer suicide. And every farmer suicide, 5th suicide is committed in Maharashtra. So Maharashtra is very high. Maharashtra farmer suicide rate is 60% higher than the general suicide rate. This is quite interesting. Farmer suicide account for approximately 10% of all suicide in India. This is Times of India, May 2017 report. If you see the causes of the suicide, the highest is farming related, 19.5, but still higher is bankruptcy, indebtedness. I'll go into more detail the reason other thing. Then family problem, illness, substance abuse is a big problem in farming sector. So this is India, and this is Varna where I am working, and this whole area is known as Vidarbha. It got 11 districts. So when there was a farmer suicide, I started working around 2004 and 5. There are 18 taluka in Varna district. In North India, they call it tehsil, or in UK, they call county. So in 15 months' time, 2005 to 2006, there were 30 suicides. So it comes to suicide every month. And the mean age was 48 years. And all the suicide committed were by males, not by females. So I've not seen any of the female who committed suicide in Varda district. Most common cause was poisoning because pesticide is easily available, then jumping, then hanging, and so on. Because pesticide is easily available, so I will discuss how to prevent the farmer suicide. And the reason for suicide, there are two types of loan. One is direct loan, when they take the loan from the money lender or the bank or cooperative banks for farming, like buying the seeds. Indirect loan is they are they are taking the loan from money lenders or the bank for digging the well or marriage of the daughter, and thinking that when the crop is good, they will repay. So this is known as indirect loan. So suicide was more seen in the indirect loan. So it is almost 50% and 30% in the direct loan. Then there are some physical illness, mental health problem, 3%, and depression due to medical conditions, psoriasis, 3%. So this is quite interesting. And alcohol problem is a big problem. Varda is a dry district. Just you to let know that Varda is a dry district, but alcohol is freely available, and this is a difficulty. Now, in when I was working in the village, we found that many of the farmers they want to quit farming. 40% farmers told that they don't want to do the farming. Like finally, what is happening? The children of the farmers they are not doing farming. They are going to job. They are becoming teacher. They are going to army. This is what happening. Now, pesticide in the community place. In couple of studies, we found that if you keep the pesticide at home, then suicide rate in farmers are higher. If you keep the pesticide in the field or keep the pesticide in the Gram Panchayat, the community center, then 50% of the farming suicide has come down. And when the pesticides are kept in the community place, then there are two locks. One lock is controlled by the Gram Panchayat, other lock is with the farmer. And I have seen one of the farmer when he wanted to commit suicide, he went to community center. On the way, he changed his mind and came back. So studies showed 50% suicide comes down. Coming to loan, the loan is again a big big issue. There is no proper evidence that loan waiver and subsidies reduce suicide. So loan waiver is not a solution for prevention of suicide. Even data suggested that the loan which is taken from the money lender, which is the interest rate is very high. I will show you as compared to the bank and cooperative bank. And it is very difficult to take the loan from the bank. It is very easy to take the loan from the money lender. Interest is very high. It is around 25 to 30%. If you see this, the money lender continue to offer loans at interest rate between 24 to 50%, and they whole life is only paying the interest. They do not pay, they are not able to pay the basic amount of money. And he has done a good work. Sainath, they call it Sainath. He also feels that loan waiver is not a solution. Unni Krishna feels that loan waiver was not a permanent solution for farmer problem. The surprisingly, government had announced to double the farm income by 2022 this year, but there was no blueprint on this scheme. So we need a proper blueprint. Compensation is a big issue. They think that if the compensation is given, the things will improve. But subsidy, loan waivers, crop insurance, and other welfare schemes have failed due to improper implementation. And worse still, compensation after suicide has sometimes provided a incentive for the suicide. There is a movie, I'll just show you some of the photographs of that. Is compensation incentive for suicide? So this is a movie people like. You get time, please see it. Here they are showing that one of the family member tried to commit suicide to get the money so that that poverty will come down. So this is quite interesting movie, people life. See it. Its shooting is done in Madhya Pradesh. Again, the frequent loan waiver. Suppose you waive the loan for this year. What about next year? Who will pay? From where the money will come? Now they are using this revdi culture type of thing, in politics. So this is not a solution. Solution is something else which I'll discuss. Now we did another study that when there is a suicide in the farming community, then what happened to their family members like wife, parents, and children? We found that the survivors of the person who commits suicide, the wife, father, mother, or children, grown-up children, they got higher higher chance of having suicidal ideas as compared to controlled. So we want to help this family survivors. There is a Kisan credit card. This is quite interesting. But most of the scheme of government of India, many of the farmers they do not know. So we need to do something so that they should know what are the schemes. National Geographic interviewed me for about 3 hours, 1 hour every day for 3 hours, and they published the my opinion on National Geographic. This was in 2017, August 2017. So these are the findings. I will not going to read it. Just these are the salient features that depression, alcoholism, suicide, global warming. So now we are concentrating here the effect of global warming on farmer society. It's a new area which is going on, and we want to do more research in this area whether global warming causing farmer suicide. So there is a climate change here, then there is a global warming, the loan from the bank, then there is a poor monsoon, and they are totally dependent on the monsoon because there is no other source of water. Then there is a crop failure. Once there is a crop failure, there is a reduction in the crop, and then there is a debt. They are not able to pay the money. Then pressure of the bank for the debt collection. There is lots of pressure, and they pay the money back, and they commit suicide. Or if there's a debt, then they become depressed, or they indulge in alcoholism. So alcoholism causes depression, and depression causes alcoholism, and both causes suicide then. So this is a diagrammatic representation of the how climate change causes farming suicide. So we are going to now plan multi-center study, and we are going for about 5 years research in this area. This is Down to Earth magazine, where they published my interview about the farmer suicide. This is very interesting, and you can read it. These are some of the photographs where we interviewed the survivors of the farmer suicide family, and this is very painful work because when we go, they think that we are here for government people and we are going to give compensation and money. But we have provided them helpline. We have asked them to contact us by text messages if they suicide ideas, and we help. And that has reduced the suicide in the farming community. How to help? Goat farming is the one of the way. Goat is commonly known as poor man's cow. So goat farming is most important. The goat subsidy around varies from 25 to 35% of the total cost of the goats or goat project. Subsidy may be applicable to shed construction, feed cutter, and milking equipment. This is provided by the government to support them. In Maharashtra and Karnataka are the leading position. The rest of the states are quite behind. So it is available. People should know that there is alternative farming. What is alternative farming? Goat farming. You can see some of the photographs of the goat farming. Then poultry farming, they can go for poultry farming, eggs and other things. This is solar panel where pump can be used, water comes out, government gives subsidy, and below poverty line they give almost free. This is quite interesting, this is a street food, what you call it, and this is corn, and then this lady is using with the solar panel, so you can do that. This is something new. When when there's no monsoon, you see the land looks like this. This is very painful to see and work. These are my loads of publication on area of farmer society, and you can just go to PubMed and find out, and if you are interested, you can read it. Farmer suicide not only in India, it is all over the world. It is across culture. There is one paper, farmer suicide across culture. One of the papers is farmer suicide, whether it is a fact or a myth. Couple of guest editorial. I think I'll stop here. Thank you very much.
Thank you very much, Dr. Prakash Behre, for this wonderful sharing of your experience and years of hard work.
And because I am out of India, I'm presenting from out of India, so I can't talk.
But still, it is an important presentation, even though virtual, and we have all benefited. On behalf of the NAMS, we thank you. And I am sharing with you the citation that is given from the National Academy of Medical Sciences, along with and there is a check also which goes along with this oration. So thank you so much.
Thanks.
So special thanks to Dr. Behra for joining us online. Thank you so much, sir. And now we'll break for lunch. Before we break for lunch, I would like to thank all the three chairpersons who have been in the pre-lunch session. Thank you so much for your contribution. So I will request you to also join after lunch, sir. Thank you so much. We'll have lunch at 2 o'clock. Lunch is outside the building on the lawn. So please join for lunch. Thank you so much.
चार्जिंग पे लगाना कोई कोई है on the point है what is your name you take care of it
Okay, good afternoon. We are starting the post-lunch session. So now I invite Dr. Ashish Banerjee to present his oration, and I request Dr. Sanjay Wadhwa to chair this session, please. Thank you so much. उनको बता दिया।
Thank you very much, Dr. Shud,
Good afternoon, sir.
and good afternoon to
Sir,
every one of the council members of this august body and to general members of National Academy of Medical Sciences, as well as to all the people in the audience.
sir, may I request for the honor to introduce you as well as
Sure.
the oration as chairperson? Yeah, thank you. Dr. R.V. Rajam oration was instituted in the celebrate on his or her
And here I start with my topic of the day. So, you see, I am a basic scientist from my background, and we are doing some molecular genetic analysis of samples gotten from female genital tuberculosis, particularly women who were reporting to IVF clinics. And you will see, in course of that, we further lend credence to the hypothesis that sexual transmission of tuberculosis can happen. This was not a very common idea even half a century back, because tuberculosis is the archetype of slow but steady kind of pathogen. And the general criteria for other bacteria that are sexually transmitted are quote-unquote fast and loose, like Neisseria or Trypanoma or chlamydia, mycoplasma, genitalium. So that's why it was not really entertained much in the, even in the previous century. So we all know aerosol route is there. Later on, you will see in 1918, actually, 2018, only a few years back, 5 years back, a Japanese group reported via genome sequencing, they had similar, another set of couple whose male partner had tuberculosis, and that got transferred into the female part, female counterpart, like a year later after they got married. So this kind of, and they did genome sequencing. It's Kimura et al.'s paper, and they did genome sequencing of both the isolates from the husband and the wife. And they could see, except for one base pair position, the entire genome is identical. So that leaves almost no other option but to say that it must have happened via sexual transfer. But thereafter, a lot of work they're being done even in Kolkata area by some clinics, and this term, LGTB, latent genital tuberculosis, was coined by our famous predecessor, Dr. Baidyanath Chakrabarty, and later on, his disciple who collaborates with me, Dr. Siddharth Chatterjee, he analyzes LGTB women. LGTB means these are women who have tuberculosis in their lower areas of genitalia, particularly in endometrium, but that shows or displays no symptom. But if you do PCR analysis, you can pick up signals for tuberculosis or even other mycobacteria. I'll come to that. But even then, it was not clear whether those samples, TB samples gotten from the women, they were coming top down from secondary or primary sites of tuberculosis. However, we then embarked on a way through patient selection that would resolve this question. So recently, you will see from this slide, we have selected almost 81 cases of unexplained infertility. And they also, this is very important, they also did not have either PTB or EPTB to start with, these women. So there is no way they will acquire the tuberculosis infection of their lower genitalia via top-down transfer or dissemination. So we took a population like that and we did our molecular analysis. So if we do molecular analysis, we did a typing by multiplex PCR. And in this technique, the TB strains or TB isolates can be divided into two groups. If you are using probes based on ISS 6110 insertion element and also probes that are designed from HSP 65, then you can get two different patterns with the TB strains. And one is, and this was demonstrated in 2001 with other TB isolates by Vasudev Bhattacharya and his group. And it became interesting because what we saw, and then there are two groupings of TB. One that would give a band of 541 base pair, higher band, and another of 165 base pair. That's one group. And then another group of TB, which we call actually group 1, which is giving only 541 base pair signal. And group 2 gives 541 and 165. And we also observed that non-tuberculous mycobacteria, NTM gives only 165 base pair bands. So we could, depending on that characterization, we could show that this is the group which is only endometrial genital TB. We could show that when we have the transfer is mostly trueness of transfer, i.e., excuse me for a second. And here you will see mostly whatever is the pattern of the male partner. If it's 541, the female gets 541 signal. And if it is 165, the female counterpart gets 165. However, there were a few cases, you see, which has two bands, 165 and 541. That can be two possible scenarios. One is, it can be the TB strain of type 1 that I described, or it can be a mixture of TB strain of type 2, which is only 541 BP, and NTM, which gives only 165 signal. So we further investigated that, and these are the gel patterns, and you will see, if you can read, these are male-female partners, and most of them gave the same type of transfer. Upon transfer, the woman got the same type. And they can be analyzed by gels. Sometimes in our assay, gels will be very good, like the right-hand panel. Sometimes they won't be that good, but still they would be scoreable. You can score them based on your observation of the gel. So what happens? Our group C, here I'm running backward, Group C does not give, so we had 81 isolates of unknown cause of infertility. But out of them, like 21 did not show any TB signal. So these were like negative control. And there you will not see any multiplex PCR band in any of the cases because the husband to start with doesn't have, so wife doesn't get. And then we had another group where you see the husband had it and transferred mostly true type of transfer to the woman. However, there were some exceptions, and I'll come and analyze that. But in group A, that also happened. In some cases, the numbers changed a little bit. And what I mean will be better understood if you look at this bar diagram. So here, I'm showing you that 165 base pair isolates, which are NTMs, only 165 base pairs. So NTMs transfer almost truly, but they gained couple of, women have couple more in case of NTM. And the type 1 TB isolates, which are two-banded in signals, they started in male with 2 more and went down by a number of 2. And however, the third type of TB, that is producing only one 541 base pair signal, that transfers entirely truly. And this is of group A, which is POC, where the bug enters or bug destroys the embryo and POC results. And as a resultant, it gets aborted. So what happens, then we analyze this, and now we even did rDNA sequencing, and what we could see that this increases number. So this is, what is happening. Here we had a mixed population. And in some of the isolates, and those isolates, when they got transferred, they, we had both NTM and TB of type 1, two-banded, and then that didn't get transferred, but actually NTM only got transferred. So, and exactly the numbers match. So if you gain 2 here, from this group, you lose 2. So there, but the other 2 were actually TB, the two-banded TB, so that got transferred truly. So by doing this, we can say 2 things. One, yes, trueness of transfer is being maintained. And secondly, we can say that there is a preference. In some cases, we can rationalize it by various types of explanation, but bottom line is in some cases, NTM is working better in terms of transfer and lower genital colonization than TB. Maybe it's faster growth or whatever can be the likely reason. We are not there yet to claim the reason. So overall, and this is again a very rudimentary and preliminary model, but we think what is happening is from male, two types of infections are happening. In one case, the bug, and this must be the whole bug, which is going to endometrium and colonizing there in the mucosa. And in the other case, it's getting transferred, and we don't know whether those are live bugs or lysed bugs, bugs broken down, and their virulence products are working. But as a result, the forming embryo gets infected, but not the mother. And it results into POC because the embryo dies. And as a result, obviously, the ultimate consequence is abortion. So now, what are the outcomes? I mean, obviously, we are lending more support towards sexual transfer of TB hypothesis. But additionally, we are doing something practical also, because now IVF is available to many of the women, particularly even lower middle class women. And in order to help them, it is important to screen the semen of the counterpart. And if we can do that, then we can identify who are the people with risk factor of later, with failure of either conception or successful childbirth. So there are many other small things written here also. In India, it's very important because in India, you know that TB is epidemic, and the number of even FGTB is very high. It's like 18 to 20% of all extrapulmonary TB. So with that, there is a large pool of women suffering, particularly with respect to having successful childbirth due to this problem. And if this is investigated more, we'll get to help those population of women in a good manner. So our future goal is to sequence these isolates. If we can sequence these isolates, and then with genome sequencing all the other types of isolates, pulmonary and different extrapulmonaries, they are already sequenced. And even some genitals which came down from primary and secondary sites. So if we match them, we may not, but we may, the chances are there that we'll see some unique loci or genes in these transferable TB or other mycobacteria, and that will give us a good mechanistic clue, molecular mechanism of what it takes to either transfer and for lower genital colonization in women, what are the genetic factors that are needed. And subsequently, we can then identify the proteins or gene products and build on that. And that may lead to further development of both diagnostic tools and interventions. But this is just, I'm being a little complaining here, but we are facing some major stumbling blocks, roadblocks. And one is, honestly, funding problem, because we wrote and submitted this grant. Actually, previously it was not funded because they said, show us the proof of concept. Now we are showing the proof of concept, but even in the last cycle, they are saying, identify that this determination was made after contribution comments. Okay. So they are saying diagnostic techniques, match it with other standard diagnostic techniques and prove it, because PCR is prone to giving false positives. That's the main objection. However, we have 81 samples, and having that many false positives would be pretty difficult. And not only that, we showed trueness of transfer, meaning if you have type 1 TB, which is getting transferred is type 1. If we have type 2, getting transferred type 2. And if we have NTM, which has a different signal, woman gets NTM. So that much of false positive and, can be very difficult to imagine. And secondly, we are trying to do cultures, but these are all possibacillary cases. So we are having difficulty even growing cultures for semen. And then from endometrial biopsies or vaginal swab, it is even more difficult, and money is becoming a very big factor, because some of you, if you work with Mycobacteria, you know the media, particularly for TB, must have oleic acid, and it's very costly. OADC, we have given the price somewhere. Yeah. I'm done. I'm almost done. So, and obviously, some of the people who published already, like Kimura's group in Japan, we wanted their genome sequencing data. It's not published, and they are not even responding. Even in 3 months' time, I didn't get any email back. So it would be great if some of you are very important members of the medical science community, you help us getting some support and collaboration in some manners. So that's why I delved on that. Sorry. And now I want to acknowledge my colleagues. Prabuddha Gupta is a junior colleague of mine from the same department. He is a brilliant guy. Siddhartha Chatterjee is the gynecologist who runs the IVF clinic. And Dr. Vasudev Bhattacharya is now retired. He was the head of biochemistry of IPJMER, and he was the pioneer of the PCR protocol. And then Bill Jacobs was my PhD mentor, and still we discuss, and he was the real motivator for me to pick up this sexual transmission of tuberculosis, this topic. And these are all my students and proteges, kind of. So they are helping me very, very much. Particularly, they are making me learn computing more than anything. Okay, thank you very much.
Thank you, sir. I will request Professor Sanjay Vadva to honor sir. Sure.
Yeah.
So our next speaker is online. I will request Dr. Vadva to please come.
Thank you. Now, great pleasure in inviting the next orator, which is Dr. Ajay Kumar Duseja. And he will be speaking on non-alcoholic fatty liver disease the Indian scenario as a part of General Amir Chand oration. I hope Dr. Duseja is online at present.
Yes, I'm there. Thank you so much.
Yeah.
Can I start
Yeah,
the?
please, sir, a few seconds. Let me have the pleasure of introducing the oration, and after
Thank
that,
you,
you
sir.
as the orator. Yeah.
Sure, sir.
General Amir Chand oration was established in the year 1981 by Tilok Tirath Vidyavati Chutani Charitable Trust, Chandigarh, to perpetuate the memory of late General Amir Chand. This oration is to be delivered by the awardee on the research work done by him or her, especially related to non-communicable degenerative diseases, with special reference to etiology, pathogenesis, clinical or laboratory diagnosis, therapeutic management, and or prevention of such diseases at the individual or community level. I have great pleasure in introducing the orator, Professor Ajay Duseja from PGI MER Chandigarh. And on the screen, everyone can see his brief biodata. He has been holding very prestigious positions. Currently, he is professor and head Department of Hepatology at PGI Chandigarh. He is a medical graduate followed by MD, DM Gastroenterology. He is Secretary General, Indian National Association for Study of Liver Diseases. He is member of several prestigious professional associations and bodies. His areas of research include non-alcoholic fatty liver disease, ACLF, viral hepatitis, hepatocellular carcinoma, etc. And he has more than 300 publications, including 25 chapters in books. And he is a recipient of several prestigious awards also. And now I won't stand between you and the orator. So over to Dr. Ajay Duseja, please.
Thank you very much, sir. At the outset, my sincere thanks to NAMS, Professor Sareen, Professor Kapil, and the other members for giving me this opportunity to share some of our work which we have done on non-alcoholic fatty liver disease in last 15-20 years. So let me first share my screen. Are my slides visible, sir? Are my slides visible?
Yes, sir, we can see. Thank you.
Okay. Okay, so how much time do I have to cover this? Because accordingly, I'll take time.
Sir, 15 minutes is the time which is printed in the program.
Sure. Thank you so much.
Thank you.
So, as I said, I'll just take you through some of our work which we have done on NAFLD or non-alcoholic fatty liver disease. And in the next 15 minutes, I'll be, briefly taking you through our journey, as I said, in last 20 years or so in this particular area. Fatty liver disease, especially NAFLD, has emerged as a, world globally as a kind of, I would say, a pandemic, which we are fighting for last many years now. And why I'm saying this is because if you look at the prevalence of this particular disease globally, the figures are close to around 25% of the general population has fatty liver disease. These are the global figures based on certain meta-analysis. We do have some data from India, and last year only we had compiled this data. And when we looked at this data, if you can see here, there are variable figures, but we do have figures as high as 53%, 49% of the general population in India having fatty liver disease. So this 53% figure is actually based on one of our studies, which I will come down to. But then there is a very recent meta-analysis which has been done by All India Institute of Medical Sciences, and they have reviewed around 50 studies from India, including around 23,000 adults and maybe around 3,000 children. And they found that in adults, the prevalence of NAFLD or fatty liver disease is close to around, 38%, which is, quite high figure, even in comparison to the global figure of, 25%, which I said. As I said, we screened at Chandigarh, we screened around 1,000 blood donors. And these were, blood donors who were absolutely healthy and were coming to donate blood at the institute. And we did their ultrasounds, looked at, their anthropometry, and also looked at their, the other metabolic profile, including the components of metabolic syndrome and everything. And to our surprise, what we found that every second blood donor was having fatty liver, and we came out with these figures of around 53.5%. And when we looked at the predictors, they were nothing but, all the, metabolic risk factors like obesity, central obesity, blood pressure, cholesterol and metabolic syndrome. They were all independent predictors of fatty liver. So these are, very alarming figures. And I'll come down to that, is it only the fatty liver which is important? Or do we need to, kind of stratify all these patients and then see which one has a severe form of fatty liver disease, what we call NASH, or NASH with fibrosis, or even cirrhosis. So having said that, let me come down to, and these were the figures which I said are only for the, general population. But then if you look at the figures for, the special high-risk groups, say those who are overweight or obese, those who have metabolic syndrome, those who are diabetics, I think the figures are much higher. Because of the paucity of time, again, I'll not be going into the details, but there's a lot of work done on this where people have shown that if you're diabetic and obese, there are around 80 to 90% chance that you could have, fatty liver disease. So having said that, again, let me show you that since this is so closely associated with, this particular disease is so closely associated with, metabolic risk factors. So early on in our, research on fatty liver disease, we tried looking at, the prevalence of these metabolic risk factors in fatty liver disease. So the most common risk factor which we found was nothing but, overweight or obesity. Close to, around 90% of our patients were overweight or obese as per, the Asia Pacific cutoffs which we used for, BMI in these patients, and around 11% of them were lean. When we looked at all the components of metabolic syndrome, and we looked at the and we defined metabolic syndrome as per the ATP3 criteria, around 50% of them had full-blown metabolic syndrome, which means they had 3 or more, out of the 5 components of ATP3 criteria. When we looked at insulin resistance in them, it was kind of universal phenomena in these patients. So these numbers were, a little smaller, maybe around 100, 150 patients that time. But then as we started, growing, and the numbers started going up, and last year we, came out to analyze our data again, which we published in J Hepatology, of more than 1,000 patients. And again, we found that around, 88 or 90% of our patients were overweight or obese, and we were left with only around 10-12% of our patients, those who are, so-called lean NAFLD. So lean NAFLD is an entity which has been described predominantly from India and Asia, where you have normal BMI, and which means and you may not even have other risk factors for, metabolic syndrome, and still, could have fatty liver. So again, what are the reasons for having fatty liver in lean patients? I think maybe I'll show you some little data on that also. Further, I think what we did was that, again, as I said, since the numbers were growing, people are having more and more interest in, fatty liver disease. So we, in 2018, formed a consortium in India called the Indian Consortium on NAFLD. So in short, we call it as ICON-D. And as per today, we have 41 centers from the country who are participating and contributing the real life data on fatty liver disease, in this consortium. So this year only, we published the interim analysis of our consortium, and this was close to around 4,000 patients we closed. And again, if you look at the figures and look at the prevalence of, lean NAFLD, it was again, close to around 10-12%, which means that 90% of our patients are overweight or obese. When we looked at, the components of metabolic syndrome, again, I think more than 40% of them did have, full-blown metabolic syndrome, and the figures for, dyslipidemia and the diabetes are also shown here. Now, as I said, what is the pathogenesis? As I said, it is the metabolic risk factors, it is the insulin resistance. But then, what is the problem in the lean NAFR? They are not overweight, they are not obese, they are not diabetic. So, what is the kind of, the pathogenesis in these patients, those who have normal body weight and still have fatty liver disease? So, we did some work on this. So everybody suggests that there's a role of visceral adipose tissue or visceral adiposity in the causation of, fatty liver and various other cardiometabolic, complications. So what we did was that we divided our patients a small number into lean and overweight, and we did the abdominal CT scans, and we looked at the volume of their visceral adipose tissue. And what we found was that even though, the lean NAFLD obviously were leaner, their total volume, visceral and subcutaneous adipose tissue volume was lower. But when we, kind of corrected it for BMI, I think there was no difference between the visceral adipose tissue volume between lean and overweight, which actually means that even if you are lean, you are metabolically unhealthy, or you can still have, visceral adiposity, contributes to insulin resistance and the fatty liver in these patients. We further did some work on the genetic, risk factors other than the metabolic risk factors in these patients. And at that time, there was a suggestion that, the iron overload could be one of the pathogenetic mechanism in these patients. We looked at iron parameters in our patients. We also did some iron, related gene mutation studies, which is the HFE gene mutation. And we did not find, these in our patients. And we concluded that, NASH in Indian patients may not be associated with iron overload or HFE gene mutations. Further working on the, pathogenesis, both in the obese and the lean group, there is some data which is coming up which suggests that your gut microbiota could be responsible for, leading on to fatty liver and its, further, severity, including NASH. So what we did was this, that we took, the small bowel or the proximal duodenal samples from our patients with NAFLD endoscopically. We cultured them, and we found that around 37% of our patients had evidence of small intestinal bacterial overgrowth. They had higher endotoxin levels. And when we correlated that with the, the TLR expression, which is, a receptor these endotoxins, and also when we correlated with the severity of liver disease, there was a good correlation. Again, suggesting that, small intestinal bacterial overgrowth, gut microbiota could be involved in the pathogenesis of these patients. Further, on the same lines, and on, CD14 gene is a co-receptor of TLR4, which I said is a receptor for endotoxin, and we again showed that the genetic polymorphism in this particular CD14 gene, especially the TT genotype, was putting these patients at 2.5-fold higher risk of developing fatty liver disease in comparison to the CC genotype. Now, briefly coming on to the work which we have done in the area of diagnostics and in the area of the management of these patients. Again, in 2015, the Indian National Association of Study of Liver, we came out with a position paper where we gave the guidance, statements about, the management of these patients, that how these patients should be worked up in clinic, the liver clinic, and at the level of the physicians, how to look for their severity, what are the predictors of severity, and we came out with very simple, parameters which actually could predict, because we said that all fatty liver disease are not same. You can have a fraction of them, around 25-30% would have NASH, and then this could be NASH with fibrosis, and these patients usually have, higher propensity to progress on to even cirrhosis and liver cancer. So working on this, again, as I said, the consortium which we have formed, and we have now more than 6,000 patients. And as I said, when we analyze the data in around, around 3,500 of these patients, and we looked at, the non-invasive assessment, markers in these patients. And, these days, the non-invasive markers which are usually done in these patients are either FIB4, which is a very simple marker which takes into account only AST, ALT, platelets, and age of the patient, or you can just do a transient elastography. So based on this, what we found that of all the patients of fatty liver, those who are presenting to the liver clinic at various centers in this country, around 25 to 30% of them, they already have what we call significant or advanced fibrosis, which means F2 or F3 fibrosis, and they have a very high chance of going into cirrhosis. And to our surprise, we also found that all these incidental fatty liver, around 10% of them, they had already progressed on to cirrhosis. So they didn't know this. And when the fibroscan was done in these patients, they were found that they were already cirrhotic. So I think that brings us to the point that this is a major issue and a major, cause for chronic liver disease, including cirrhosis and liver cancer in these patients. Now, coming to the management of these patients, this is a lifestyle disease. So lifestyle interventions remain the key in these patients. The control of body weight, control of metabolic risk factors obviously remain the key. And the drugs are used only in a very selective kind of situations where you have a biopsy-proven NASH or you have a non-invasive assessment telling you that these patients could have, high fibrosis. There we use these drugs, the pioglitazone, vitamin E, and the saroglitazar. So in this area, again, we did some work on this, and initially we worked up on the, lifestyle interventions, and we did show in a small group of patients that I think if these patients advise adequate aerobic or anaerobic exercises, and if they are able to lose, say, maybe around 7 to 10% of their body weight, we can have biochemical remission in these patients, and this can translate into even histological remission, and there's a huge data, which is available for that. About the usage of drugs, that time, I think that there was an era of using the insulin sensitizing drugs. As I said, the drug of choice which is used these days is either vitamin E, pioglitazone, or saroglitazar. Both saro and pio have insulin sensitizing properties, but at our center we used metformin in some of our patients and showed that especially those who are not responding to lifestyle interventions, metformin could be a good drug which can help us again in achieving the biochemical response. We also showed about the relationship between the vitamin D deficiency and the improvement of, the, again, biochemistry in these patients and the improvement of, adipocytokines in these patients. If you give vitamin D to these patients of fatty liver, those who are vitamin D deficient. In one of our recent study, which was a 2-center study, we came up, this is a PGI and an AIMS work, where we came out with this concept that if the the gut microbiota, if it is involved in the pathogenesis, then the modulation of gut microbiota should help in these patients. So we tried using a high potency multi-strain probiotic in these patients. And as I said, this was a proof of concept study, and where we did a baseline liver histology, liver biopsy in these patients, gave them this probiotic for an year, and did the second biopsies in these patients. And what we showed was that there was not only improvement in biochemistry, cytokines, but there was also improvement in liver histology in these patients with probiotic. Finally, I think we need to admit, and we all agree, that fatty liver disease, is not only that it involves only liver. This is considered as part and parcel of, a multi-system disease. You have a metabolic milieu, which can affect not only your liver, but can affect your heart, can affect your kidneys, lungs, and everything. So in this area also, we have worked on this, and we have shown that patients with fatty liver disease not only have, higher atherosclerotic risk, looking at the carotid vessels, they also, if you calculate, the coronary artery risk score in them, they are much higher in these patients. We also looked at the renal dysfunction in these patients, and we found that, yes, these patients are at a higher risk of having renal dysfunction, and which is related to the severity of liver disease. We also looked at the relationship between the obstructive sleep apnea and the fatty liver disease in this patient. I think the journey is still long. We probably have to do a lot, but to summarize, I can only say in one sentence that I think we've done a lot. India has done a lot in fatty liver disease, but I think we still have to do a lot. Yet more is required to, contain this, pandemic or epidemic of fatty liver disease, which is going on throughout the country, and as I said, Asia Pacific and globally. And the inclusion of fatty liver disease in the NPCDCS the National Program for the Control of Diabetes, Cardiovascular Disease, Cancer, and Stroke is one such step which has been taken by, the Ministry of Health and Family Welfare, which will definitely give boost in controlling and preventing this particular pandemic. So thank you very much for your kind attention. I'll stop sharing my screen. Thank you very much.
Thank you very much, Professor Ajay Duseja, for this masterly presentation. I am sure non-hepatologists also must have got the message that you wanted to convey. Thank you.
Thank you, sir. Thank you. Thank you, sir.
Professor Duseja, since you were logged in online, so I have great pleasure in presenting this citation on behalf of National Academy of Medical Sciences. And along with this citation goes a check. And the Office of NAMS will ensure that it reaches you safely. So congratulations once again.
Thank you very much. Thank you. Thank you.
So next speaker is Dr. Amit Rawat. Please come on the stage. And I will request Dr. Velu Nair to lead the session.
So the next oration is the Dr. Khanolkar oration. And we have Dr. Amit Rawat to speak on the targeted next generation sequencing, also called NGS, for primary immunodeficiency diseases at a tertiary care in North India. Just a word about the Dr. Khanolkar oration. Initiated in 1987 in the memory of Dr. V.R. Khanolkar, who also happens to be the first president of this academy. This oration is awarded to an eminent biomedical scientist in recognition for his or her work in translational research, including, amongst others, gene therapy, biological therapies, genomics-driven cancer therapies, and regenerative medicine. This is the way the world is going today, actually. And we have Dr. Amit Rawat, who's been awarded this year's oration. He works as the professor of pediatric allergy and immunology in the allergy immunology unit in the Advanced Pediatric Center in PGI, Chandigarh. Very well published, more than 216 publications. And the special areas of interest are inborn errors of immunity, complement deficiencies, antibody deficiencies, SLE and other autoimmune disorders, and in primary immunodeficiency diseases. Dr. Amit Rawat.
Thank you, sir, for the kind introduction. Foremost, I would like to thank the National Academy of Medical Sciences for conferring me with this oration this year, and I'm truly honored and humbled to be presenting the oration which is named after a stalwart in pathology, Dr. Vaswant Ramji Khanolkar, who is also fondly called the father of Indian pathology. So the topic of my oration is targeted next generation sequencing for primary immunodeficiency diseases in North India. So what are primary immunodeficiency diseases? So primary immunodeficiency diseases, which have now been rechristened as inborn errors of immunity, are a group of phenotypically and genetically diverse single gene disorders which affect different components of the immune system, both adaptive and innate. A total of 485 disorders have been described till date. This is as recent as 2022. Patients with these inborn errors of immunity or primary immunodeficiency diseases have protean disease manifestations which include increased susceptibility to infection, autoimmunity, autoinflammation, atopy, and a subset of these patients also are susceptible to develop malignancies, particularly hematopoietic malignancies. Accurate diagnosis of these disorders is not only important to confirm the diagnosis and for genetic counseling, but also in the era of personalized medicine to develop tailored management protocols. So these two figures here show the figure on the left shows the exponential increase in the number of PIDs which have been described over the years. And since 1980, the early 80s, when only a handful of disorders were described, till 2021, there were close to 500 disorders which have been described. And this has all been thanks to the advancement in genomic technologies, particularly next-generation sequencing. And on the table on the right, you can see that within a span of 3 years, more than 50 disorders have been added. The blue bars show the disorders which are described in till 2019 in different categories. And in 2022, in each category, several disorders have been added in just 3 years. And this is again a testimony to the power of these new genomic technologies. So the IUIS, or the Indian International Union of Immunological Societies, has an expert committee for classifying these diseases. And this committee has classified these disorders into 10 categories. These include immunodeficiency affecting cellular and humoral immunity, combined immunodeficiency with associated syndromic features, predominantly antibody deficiency, diseases of immune dysregulation, congenital defects of phagocyte number, function, or both, defects in intrinsic or innate immunity, autoinflammatory disorders, complement deficiencies, and in the 2015 update, bone marrow failure syndromes were also added into these categories. And then we have got a category which is known as phenocopies of inborn errors of immunity, which includes patients who have somatic gene variants and also patients who have defects in increased susceptibility to infection because of autoantibodies to certain cytokines. So this was the most recent publication on the, this is the 2022 update by the expert committee of IUS. And in this, they have described 485 disorders in these 10 categories. So these are some of the members of that IUIS committee. Most of them are from North America, but there are members from Middle East, from Asia, from Israel. So why is the genetic diagnosis of inborn error of immunity important? Does it matter? I would argue it is, because it certainly provides a definitive diagnosis and at times resolves a diagnostic odyssey. But what happens in these disorders is that the technical wherewithal to diagnose the disorder is not available in most centers in our country, and the patients have to wait for as long as 10 to 15 years for a correct diagnosis. It has got implications for targeted or personalized medicine, as I've already alluded to, and these patients can have unusual or atypical phenotypes with defects in known genes, and there could be new genes for previously described phenotypes. Sometimes it helps in advocacy for patient benefits, as we know that the rare disease policy has been formed and some patients do benefit from these policies. It has implications for undiagnosed family members who could be carriers or who could be affected with the same disease but would be asymptomatic at that point in time. It certainly helps in genetic counseling and antenatal diagnosis. And more recently, it could also help in pre-implantation genetic diagnosis. So what are the different methods of genetic analysis which are available? So Sanger sequencing has been around for quite some time, and it typically is used to sequence individual genes or exons of individual genes. And then we have this technique which is known as next generation sequencing, which has been around for two decades, more than 2 decades now. And it comes in different flavors. So we've got targeted gene panels, exome sequencing, which provides you data about the coding region of the genome, and then we have got whole genome sequencing. Other techniques such as RNA-seq or RNA sequencing is more in the realm of research right now and not really impacting clinical decision making. And for copy number variations which cannot be detected by either Sanger, by NGS, we can do either a fluorescence in situ hybridization or chromosomal microarray. So the different levels of genetic testing have been described here. The Sanger sequencing is of course the gold standard and has been around for quite some time. It can detect splice site variants. The data, however, is limited to specific genes, and it is definitely expensive when you calculate the cost per nucleotide to sequence, and it is definitely slow. NGS, as I said, it comes in different flavors. You have NGS gene panels, which have got a fewer handful of genes. The coverage in these NGS panel is high, and so you can detect somatic variants, but the data is restricted to the genes which you have included in this panel. It is relatively inexpensive. It can detect some splice variants, but intronic and other splice variants might be missed. It is rapid. The exome sequencing has got moderate coverage, typically 30 to 100x. It has an inherent bias based on the capture method which has been used. It is less expensive, it is rapid, but indels are missed. And finally, in the exome sequencing, there is limited data coverage. However, it is a very bias-free approach. It can detect data on non-coding regions. However, it is still expensive, and it is less rapid not in the sense of the doing the wet work, but in data analysis, because you've got humongous data when you get sequence the whole genome of an individual. So this, the figure here shows the cartoon here depicts Sanger sequencing. So it essentially comprises of two different steps. The first is the amplification PCR, where you design primers specific for an exon. You use DNA polymerase, deoxy NTPs and primers. And finally, when you've got the amplified product, you clean it and then you subject it to sequencing PCR, in which you use a mixture of dideoxy and deoxynucleotide. So wherever a dideoxynucleotide is incorporated, there is chain termination, and then you get these different fragments by capillary electrophoresis, which give you a readout of the genetic sequence. The NGS, there are different platforms which are available now. The most widely used is the Illumina platform, which uses a technology, patented technology of sequencing by synthesis. Then you have Ion Torrent, which uses a method of semiconductor-based method of electrochemical sequencing. Single molecule real-time sequencing has been used by PacBio, and nanopore sequencing by Oxford Nanopore. It utilizes the change in electric current when the when nucleotides are incorporated through a protein nanopore. So these are different technologies. The Illumina and the Ion Torrent platforms give short reads, and the single molecule real-time sequencing and the nanopore give long reads. The other methods which are useful are fluorescence in situ hybridization and array CGS, as I've already alluded to, and these are important to detect copy number variations. So what we have used in at our center is targeted NGS, the Ion Torrent-based platform. So the Ion Torrent-based platform is based on semiconductor technology, and whenever a base is incorporated into a growing nucleotide chain, there is a release of H ion and change in pH, and sequential nucleotides are added, and whenever there is a complementary nucleotide, the base is incorporated, H ion is released, and this is read off as this is detected and the base is called. So we have designed 5 targeted NGS panels. The most common one we use is a PID gene panel with 44 genes, although there are 10 times the number of genes in the IAIs now, but we designed this panel keeping in view the common genes, genetic defects that we found at our center, and also to limit the cost. We have a complement gene panel of 25 genes, type 1 enteropathy, 24 genes, and then we have a Mendelian susceptibility to mycobacterial or fungal disease with 34 genes. So briefly, the workflow: first we prepare the library, then there's template preparation, and then we do DNA sequencing, followed by data analysis. So first DNA is extracted and quantified using qubit. Then we have a library preparation when we do emulsion PCR, then followed by enrichment, and the chip is loaded onto the instrument, and then we get the sequencing data, which is put on the inbuilt server, and then we get a VCF report, or we can also analyze the raw BAM files to get the VCFs ourselves. So this is how the NGS data looks on a integrative genome viewer. So you've got a reference genome at the top, you've got variant coordinates. You can zoom in and zoom out. The position of that particular area is indicated, coverage is indicated, the number of reads, variant mismatches are marked, and then at the bottom you've got reference tracks. So genetic inheritance pattern is an important factor during analysis. Clinical information you need is about the mode of inheritance, the clinical penetrance, and also genetic heterogeneity, because the same phenotype may be produced by multiple number of genes. And if the inheritance pattern is recessive, you have to look at both homozygous gene variants, and also there could be heterozygous, compound heterozygous variants from each parent. And they have to be in trans, not in cis. In case of autosomal dominant and X-linked disorders, a single heterozygous or a hemizygous variant is selected, and there could be de novo mutations in all 3 modes of inheritance. So the prioritization of variants, So there are few terms which are important. Read depth or the depth of coverage is the number of nucleotides, number of reads per nucleotide. And the more is the reading depth, the greater are the chances to identify technical errors. Coverage refers to the percentage of the targeted region covered by that panel. Diagnostic coverage should be close to 100% and the read depth more than 20x. So these are some of the softwares which we use during data analysis. We use OMIM, ClinVar, Varsome, etc. These were the results from the 5 panels over the last 4 or 5 years that we have been doing it. Most of our patients were affected with primary immunodeficiency diseases. Then we have a large cohort of patients with hereditary angioedema with a mutation in SERPIN G1 gene. We have few patients with complement deficiency, mainly early complement deficiency, 2 patients with type 1 interferonopathy, and 2 patients with Mendelian susceptibility to mycobacterial disease. The figure on the right shows the different genes. So the most common genes we found in our cohort was the BTK gene, which is responsible for the prototypic antibody defect X-linked A-gamma globulinemia, which defects males. CYBB, this is responsible for X-linked CGD. Then we have got the ITGB gene, which is associated with leukocyte adhesion deficiency. A large number of patients also with ataxia telangiectasia. And then we have got other genetic defects. So we have performed validation of our data by Sanger sequencing in some of the patients, and these electropherograms represent the same. So this was a patient with X-linked CGD and a single nucleotide insertion leading to a frame shift mutation. This was in the CYBB gene. Similarly, a single nucleotide substitution changed from arginine to glycine at 618 in a patient with X-linked gamma globulinemia. And the lower panel shows a patient with leukocyte adhesion deficiency with a stop gain or a nonsense variant in the ITGB2 gene. And NCF2 gene is a gene associated with autosomal recessive CGD. And this is mainly seen in North India, I mean, where we have hardly any patients reported from South India for the NCF2 gene. So coming to some of the results and observations. So the autosomal recessive CGD is caused by numerous genes, and the most common defect is by the NCF1 gene. But the problem with this gene is that it's got a pseudo gene, and whenever you do NGS, there are no reads if there is a GT deletion in exon 2. And since you have to do other orthogonal techniques like gene scan to confirm this. So as you can see from the figure on the right, the upper panel shows a patient control with both reads from a pseudo gene and from the true gene, whereas in the patient who has the GT deletion, you've got the peak only from the pseudo gene. As I've said, large gene deletions covering multiple exons may be missed by NGS. So in this particular case with XLA, there was a deletion. There were no reads from exon 10, 11, and 12 in this patient. And this was then again confirmed by MLPA, multiplex ligation dependent probe amplification. And this panel here shows the mother who is a heterozygous carrier and the patient who has got a homozygous deletion. It was found only in the exon 10 and 11, not the 12. There are some other interesting cases as well. For example, in this case, the ion reporter software, which is used for reporting the variants, called 2 close variants in close proximity in the same exon. However, when we looked at the data on the integrative genome via the BAM file and the integrative genome via, we found that it was a complex indel where 8 nucleotides were removed and 3 were added, leading to a complex indel, and this was confirmed by Sanger sequencing. Again, in a few patients with mutations in the ATM gene with ataxia telangiectasia, this was the variant which was called by the ion reporter. However, when we see it on integrative genome viewer, we see that there's again a complex indel which has been misinterpreted by the ion reporter software. So these 2 patients had got this variant in the homozygous state because all the reads show the same variant. In this patient also, the reads which are available, although this coverage was not good, but they show the same variant. And these 2 patients had the heterozygous variant. So the validation of variants of undetermined significance, the bane of NGS is that when you order an NGS or you request for investigation, you get variants of undetermined significance, and what do you do with that? So you have to do a functional analysis on variant cell lines, you have to prove what effect that variant has got on the protein function or the structure by different functional assays, and this could be very tricky and could take time. The limitations of NGS are that it's got its analytical sensitivity, the difficult to sequence areas, for example, the deep intronic areas, the areas with homopolymer repeats, and there is still limited in databases and knowledge, and structural variants and copy number variations cannot be detected by next generation sequencing. So also the list of genes which are being reported with different phenotypes is rapidly increasing. Copy number, okay, I'll just take 2 minutes. Semiconductor-based sequencing is also fraught with inaccuracies where homopolymer repeats are present, and heterozygous deletions cannot be detected, and so our large deletions are also missed. So in our cohort, we have done 233 patients, and we have got a higher pickup rate than other previous studies. And the rate for this that we choose patients based on a high pretest probability. We choose patients who have where we can guess the genetic defect based on preliminary immunological investigations. So these are some of my references. Finally, I would like to thank all my colleagues, students, PhD students, research staff, technical staff, both in the clinic and in the lab, on whose behalf I stand and receive this oration. And I also thank my funders, Indian Council of Medical Research, Department of Health Research, Department of Science and Technology, Jeffrey Model Foundation USA, and the Department of Science and Technology, Scientific and Engineering Research Board, SERB, for their generous funding. Thank you.
Thank you, Dr. Rawat. Actually, this is one of the areas of rare diseases which actually the government of India is recognizing more and more. And ICMR has led the way, as you know. And I hope you collaborate with NIIH in Mumbai, who have got a center of excellence for PIDs.
Just to tell you, sir, we were the first center which was recognized before the Mumbai center.
Great.
So we were recognized in 2015.
So you must collaborate. That's the way to go for rare diseases.
We are collaborating, and our center is also one of the nodal centers in North India for these rare diseases, particularly PIDs.
Great. Congratulations and a very good talk. Thank you.
I will request Dr. Velu Nair to honor Dr. Rawat, please. Professor Rawat. So now I invite the next speaker, Dr. Pragya Dhruv Yadav, please. And I will focus.
I have the pleasure to introduce the next speaker, who's well known to me, Dr. Pragya Dhruv Yadav, who's actually working in NIV Pune. But before that, I'd just like to introduce the oration she's got. Dr. P.N. Chutani Oration, a giant in the field of medicine, as known to most of us when we were students, actually. This oration was instituted in 1999 in his honor, and he's a past president of the academy. And the oration, which is awarded to a basic research scientist who has worked in this field to elucidate the pathophysiology, clinical and lab diagnosis of such diseases at the individual community level. I don't think they could have chosen a better orator. Dr. Pragya is one of the most energetic researchers that I have known, and she's the custodian of the only biosafety level 4 laboratory in our country, which is in Pashan in Pune. And she has been very closely associated with the COVID-19 pandemic, right from elucidating the sequencing of the viruses, and besides in the basic setting up of Covaxin vaccine. The whole virion was actually identified by them, given to Bharat Biotech, who went on to make the Covaxin. So she's been a pillar in the story of Covaxin. What amazes me is that she works on a horizontal landscape of viruses from Nipah. On Nipah, Zika, CCHF, Kayanul forest disease, and now the monkeypox. And Dr. Pragya, you're going to remain busy because the viruses are going to keep coming, whether it's from China or it's from elsewhere. But they are going to keep coming, let me tell you.
Right, sir.
And what is important is she has contributed to infrastructure building of investigating all these breaks of virus disorders at epidemic, endemic, and pandemic levels, and to set up and strengthen the laboratories in our country, which is so important. So I think capacity building has been great, and that is shown how well you are published, more than 275 publications, with a huge impact factor and citation. Well done, and we want to hear. The stage is all yours.
Thank you so much for such a kind words, sir. And I'm really thankful to National Academy of Medical Sciences for choosing me for this oration. And I thank the present president, former president, the chairman of the committee today, for all three of you. And I know many of you, and it's really my privilege to stand here in the NAMS and do this oration. So if you look at the screen, the picture which show the kind of work we do. So we work on all high infectious disease, which just sir has said few names, and anything which is unknown and can kill human or animal beings. So we goes to business immediately when there is an unknown, new, emerging or deadly disease outbreaks happen in our country. We also serve to CR member state because we are also WHOCC for the region. In the left side, a two-person working in a biosafety cabinet present the BSL-3 PPE. In the center is a BSL-4 practices PPE, which we call Delta suit. And in the corner, we have this BSL-4 facility, which sir mentioned only one facility in India and earlier or only in Asia, where we do handle all infectious pathogen currently. So, as you know, everyone knows about the COVID-19, even a small child today, because of the suffering we have gone through in last 3 years, and it still is continuing with emergence of different variants. So in the center, if you look at, there is a figure which is speak different variant of concern, which was not present till September 2020, but then a new game of variants started. The COVID was a problem from the beginning, but now there was a game change of emerging variant of concern, which was initially alpha, then it became beta, and then gamma, and the delta was the one wave which we call the second wave, when we seen the maximum worst part of the country where people were dying, hospitalization were huge, and everyone either has got infected in the past or lost somebody very dear one during the COVID pandemic. So this is a disease which we will not forget in our life, and even the youngest children which we are with us will not forget this pandemic. But still, this pandemic has taught a lot. It has given a lot of hopes for technology and the self-reliant country for the India, because we really did a lot of efforts in this country. So the vaccine and also the drugs and R&D research. So if you look at the 3 different waves which happened, in the first wave, when we were not having any reagents, there was no capacity and there was no PP, in fact, when we started. In the second wave, we seen the worst part, and then in the third wave, when the Omicron happened, though cases were still very high, and if you look at the total number of the cases and death, it's really huge. And India also represents the second highest country where we have the highest number of the cases. And in spite of that, during the Omicron wave, we could survive. We didn't see the death and mortality which happened in the Delta wave. And this happened because of only a great immunization program conducted by Government of India and the researchers and the pharma company who went ahead and made it on time. If you just imagine if we could have to borrow the vaccine from any other countries, I don't think we could have survived in this pandemic, because nobody will give it such a huge number of the vaccine for a country like us, who is the secondly most populated in the world. And the impact of the COVID, it is humongous. We cannot even measure and count how much loss we have done. Either it is about the human lives or the social, or even the worst is the economy, and everybody assume that if you, the wars which is going with the virus or disease or anything, bioterrorism, the biggest impact you can make on the economy, and that was the one which we have seen recently. So during this pandemic, the biggest challenge started the first identification of cases, enhancing the laboratory, and then enhancing the detections. And then there was a plethora of challenges, how to do research, how to come up with the vaccine, because there was a huge race for the vaccine. And the UK came up with the Chadox vaccine, and which was started by Serum Institute to build up, but we also need to have more vaccine on the platform so we could deliver to the country. And that was the time we detected the first 3 cases in January from Kerala, from those Wuhan students who arrived. And we sequenced, and then we started enhancing the laboratory. But that was the time we also started thinking how to go ahead with the vaccine. And that was the time when we collaborated with Bharat Biotech to this direction. But to reach to a vaccine which should be indigenous in a situation when there was an international lockdown and there was supplies issues, and even there was a lot of other challenges, we need to have a complete setup to make a new vaccine for a disease which is not known, and there was no reagents available. So you have to make the whole setup to do those research. And also, more than that, there was a lot more challenges to track those infections and variant, because the virus was mutating fast, and you need to know what is going to happen to the virus. So with all these challenges, we initiated. If we look at the different platform of the vaccine, there are many, but the inactivated whole virion-based vaccine is one of the oldest vaccine platform, which was made 100 years back and is still very effective, and it has a lowest side effect and being used for many other vaccines. So, and this was the easiest way because we didn't have any messenger RNA technology or adenovirus technology, so we decided to go ahead with the most safest traditional method, which can be very effective. But the same vaccine platform has been used for polio, H1N1 rabies, and JE vaccine. If you look at the timeline for development of any vaccine, in the past, the vaccine take around 15 years to develop and come in the market. The reason was 2-3 main reasons. First, choosing a right candidate, doing the preclinical studies, going for the clinical studies, and then post-clinical, the real data analysis and efficacy study. And there was a lot of paperwork and regulatory framework involved, which take long time. But during the pandemic, everything become online, digital, and that actually is speed up this, the race. But at the same time, everybody realized the importance of the vaccine, and everything was fast-tracked. So during the pandemic, the vaccines were developed between 10 months to 1.5 years, and that was the reason people has a lot of doubt on the vaccine. And every vaccine has to prove time to time that vaccine is safe, it is effective against variant of concern, and the challenges were not stopped till now. So every day you have a new variant and your thoughts provoke you, do need to do more PRNT testing, do you need to look at the efficacy study? So, this virus become a challenge for scientific community. And when we started this journey, there was a lot of challenges to pull together how we are going to make this vaccine. And we had the lockdown, we have scarcity of reagents, and then we need to train many new members because we have to do this study in a containment facility, which you have seen that it seems very cumbersome when you work in a containment facility, and if you are not very well practiced, you cannot work in those structure. Working in an outside facility, our laboratory is a lot easier than working in a containment facility. Then we wanted to have all those infrastructure which is required to conduct a study which can par with the international standard for the COVID, and where you require all those surgical equipments and also the latest technologies of bronchoscopy, which sir has mentioned, and it has to be implemented in our containment facility, doing X-ray, which is not part of our routine research. So there were some very crucial challenges, and which we dealt with a lot of support from many government bodies. So the teamwork is one of the main mool mantra for the success of the Covaxin, which is India's first indigenous vaccine and could be implemented in so many countries. So we've isolated the virus from clinical sample from the first cohort of the cases which happened in Delhi from the Italy tourists who arrive in Delhi, travel to Jaipur. And then there was a journey of developing our ELISAs, PRNTs, and many other tests, establishing many SOPs for proving that how much time virus take at the highest propagation, if the virus is stable enough to do or make a vaccine. So these were the plenty of the test assays, and there was no time. We need to establish the animal model, that which animal is susceptible for doing preclinical studies. So you can imagine if there is a pressure and there is a need, and there was a feeling that many people will die, everybody was on the toes to work very fast from the top to bottom. So these were, and everything, and every study which we did during the pandemic, we publish everything. Either it's a small protocol, or a small technology, or a small findings we try to publish. So it gave a lot of visibility that we are working in a right direction, and we are very honest to our studies. We developed this first COVID Kavach ELISA, which gave a lot of boost because there was no serological test available, and the tests which came from other countries were not functional. And this test actually became boon of our studies during this vaccine. The virus which was characterized very well and with the SOPs was shared with Bharat Biotech. They made the first batch of the candidate vaccine, shared with us. We checked for their properties, EM structure and other things. And then we started our first pre-clinical studies. The 3 formulation was made, and there was a new component included. L-gel is the one of very known LM which we call adjuvant used for the vaccine, but in this vaccine we used also one of more additional component is called IMDG, and that actually helped improving this vaccine. So the role of this IMDG was not only giving the humoral response, but also the but also CTL response, which we have not seen earlier in other vaccines. So with this, we initially tried in 3 different animal models that included Balsi, rats and rabbit, and all the vaccine candidates provided very good safety, antigenicity and immunogenicity. So that was the first step where we realized the vaccine formulation is very well working. Then the next step was to look at in hamster, which is a very right model to study this virus. So we give 3 doses of the vaccine to hamster, and then there was a compound, there was a kind of group which was only given the virus, no vaccine, and we could try to look at what is happening among the placebo group and also the immunized group. There was a different parameters which is laid down for such kind of studies was observed, and at the end of the studies, when we look at not only the histopathology, histochemistry, but also gross pathology and viral RNA, and also the sgRNA, which is called subgenomic RNA, and also considered to be replicating RNA was observed. And we found that the placebo animals, they showed pneumonia-like symptoms in infected animals, but those have got the vaccine, they were not showing, and the virus clearance was faster, and the vaccine was effectively working in these animals. Then there was a next challenge. The DCGI came up with the rule that for the phase 3 trial, you need to have the data of phase 1, phase 2, but you also need to come up with the data of monkeys, which is rhesus macaques, a very susceptible model for COVID. So that was again challenge to go ahead and do a monkey study. And we, in our country, we do not have, before the pandemic, we didn't have, but now ICMR has come up with the institute who is growing these kind of animals for the research studies based in Hyderabad. So we have taken these animals from forest, and they were screened like human being, doing all the TB testing, USG, and different testing, looking for each and every organs and tissue that if they have any infection. And after that, once they were grouped in 4 groups, 3 groups for the vaccine and 1 for the placebo, and 2 doses of the vaccine was given at 14 days. And then they were challenged at 28 days and observed for 7 days. And these were the 7 days where we need to observe them for each and everything. So viremia is present in each and every tissue or not, in urine, stool. And the most important to see the chest X-ray and also the bronchoscopy to see the bowel fluid is having a viral RNA or not. Based on that, we could came out that those animals who have been given the vaccine, they showed a very fast clearance of the virus from the lung, and actually in the only placebo group the virus was present, but rest of the group showed clearance, and there was no virus present in most of the tissues. And the antibody response was very, very huge. Neutralizing antibody response was also very good. And in the lung and other tissues, we could only see the virus in placebo group, but not the vaccinated individual. So this is a picture of gross pathology of placebo and vaccinated individual, which is itself explanatory that how clean the lung where the vaccine is given. The same time, so finally, with all the experimentation, which took a lot of energy, a huge teamwork of NIV scientists, including armed forces medical personnel, and also we included experts from other institutes. We came up with the conclusion that vaccine was very good working, giving a good protection, and it will be work in a human being. So that was the data. Not more than that, we also tested for toxicity and other parameters to see if it is having any impact on other issues, but those vaccinated individuals were really showing no such kind of evidence. So this data is published in Nature, and we went ahead, and then clinical trials were completed in phase 1, phase 2, and phase 3. In the phase 3, it is one of the largest trial. More than 25,000 participants were included, and the vaccine showed 78% efficacy. The efficacy data came during the Delta variant wave. So that was the time when maximum number of the infections were happening. Again, the vaccine showed very high efficacy against the severe disease and deaths. And also it showed 63% efficacy against the Delta variants. So these are the different sites which present different spectrum of the country's geographical area. And they were the vaccinated and the placebos were followed, and then we could calculate the efficacy of the vaccine. But this was the initial phase. But then we had this alpha variant in our country, started from September. And then we could see, so the 16th January was the time when government given the approval to start the vaccine program. And in the meantime, as soon as the healthcare workers got the first and second dose of the vaccine, in the March, we are started seeing the breakthrough cases. And that really make everybody believe what went wrong, why the vaccine is not working. And then, but this was not the case of India, but in US and other countries where vaccine program was running, everybody realized, and then there was a lot of race, what is happening, let's check on that. And then we did systematic study to find out what. But this is a picture which represents the different variants were studies against the vaccine. And we have to work on continuously to isolate the live virus so that we can perform the vaccine effectiveness studies. And as I explained, that March, April, May, that was a time huge number of people started coming with the breakthrough. So we conducted a study in 17 states. We collected the specimen of those people who got 1 dose vaccine, 2 dose vaccine, or unvaccinated, and we found that those people who got 2 dose of vaccine or 1 dose of vaccine, they were not have the severity, and also they were not hospitalized. Death was not there, but in unvaccinated cohort, there was death severity, and SpO2 level was also compromised. So these were the kind of data which actually help people to realize the vaccine is working, and that's how everybody came with a concept saying vaccine disease modifying tool. So vaccine is now called as a disease modifying tool, and which we realized during the Omicron wave that because of presence of still a huge number of the cases, we could not go to some worse situation. So this is a very simple data of alpha variant. When the alpha variant started coming to country, we did a study and we found that alpha variant was not affecting the efficacy of vaccines. Similarly, then initially of the Delta variant, there was a variant is called Kappa variant, and we also did a study and found that only 2-fold reduction were observed. And this study was immediately published and gained a lot of attention because this was the first study in the world where we came out with the data. The way the virus was transmitting, everybody was worried, and it really assured that vaccine will be still effective. Then further, the Delta and Beta, these were the other of the variants which arrived, and we did the study, we showed that there was a fold reduction, but yes, vaccine was still effective. Further, we work with the extensions of the Delta. Delta has a huge number of variants which evolved with the time, and there were also studies and proven that vaccine was still working. Then further in 2022, the Omicron cases started in country, and people realized during January to March that people are not dying, people are not getting to hospitalize. And then we did a study where we have taken the people who have just 2 doses of vaccine. Those who have hybrid immunity are those who are having recently infected with the Omicron, and we found that hybrid immunity was giving a lot of protections.
Dr. Pragya, 2 minutes.
Yes, sir. I'll just conclude. So with the booster also, we could came up with the data that after the 6 months, the antibody was waning. So booster is very much helpful. And the slowly government came up with the conclusion that everybody should take the booster. So the message is this at the end of the study, I would like to say that COVID pandemic is still not over. So those who have not taken vaccine, they should must take. And after, I think we will require immunity enhancement again and again. But at the end, I just thank the whole team who could make a dream of such a fastest making vaccine which is effective and accepted by many other countries where this vaccine was implemented by a government and private partnership. It has given a lot of hopes that in India we can do develop the vaccine which can be implemented at the mass level. So I thank ICMR headquarters, our former Director General, Professor Balam Bhagat sir, who was always very highly motivated, Dr. Nivedita Gupta from headquarters. She was always with us during these studies, and our director, Dr. Priya Abraham, she joined during the pandemic, and we worked with her. And this is a team of scientists who work with me, including 2 of them from Command Hospital and AICTS, Colonel Sanjay Kumar and Major Gaurav. And I have all these team who, if you see the pictures, they are all young people, and most of them are female also. So I lead a team which is highly number of female scientists and researchers, very highly activated and motivated people. And we have great mentors with us, like one of them sitting here who always encourage for doing different research. And I thank all of you to listening me. Thank you so much for this opportunity.
Thank you, Dr. Pragya. Actually, you know, we have seen the birth of the Covaxin, which has happened. It's translated. That's the important part. So that's a great news. And as you said, COVID is here to stay. And you get protected for 3 to 6 months. So we have to keep finding ways to protect ourselves, keep doing the great work, and you should not leave the tempo. Thank you very much.
So I will request Dr. Nayak to please honor. May I now invite Dr. Divya Vora, please.
The next oration is named after Dr. B.K. Anand Oration, and this is being delivered by Dr. Divya Vora from the College of Pharmacology at Jamia Hamdard. Dr. B.K. Anand Oration was instituted in the year 2004 in the name of Dr. B.K. Anand, who is an eminent neurophysiologist and also past president of the National Academy of Medical Sciences. The oration is awarded to an eminent basic medical scientist who has made special contributions related to neurosciences, alternating with a physician or healthcare professional who has made significant contribution to medical education. That is the background of Dr. B.K. Anand Oration. And about Dr. Divya Vora, Professor Dr. Divra Vohra is a professor of pharmacology in the School of Pharmaceutical Education Research at Jamia Hardat, New Delhi. She has over 24 years of teaching and research experience with significant number of publications to 180. She has, as you can see, a big biodata, and she has research grants from ICMR, UGC, CSI, DST. But more than that, I would like to mention about her research interest. Her major areas of research interest are neuropharmacology, particularly epilepsy, neurodegenerative diseases, including Alzheimer's, and associated comorbidities. Her laboratory has identified novel targets for epileptogenesis and addressed several epilepsy-associated complications. New mouse models were developed in her lab for the secondary osteoporosis in mice and novel biomarkers for epilepsy. She has done much more work on epilepsy, and I think she's going to share with us in her oration.
Thank you so much.
Welcome,
sir.
ma'am.
Thank you so much for this introduction. Respected chairs and the members of the National Academy, I would like to thank the National Academy of Medical Sciences for giving me this opportunity to present the B.K. Anand oration today. And the title of my oration is Novel Targets for Neuroinflammation Mediated Status Epilepticus and Refractory Temporal Lobe Epilepsy using cell-based and in vivo approaches. Status epilepticus, as we know, is a prolonged seizure, and whenever status occurs, it increases the risk of developing temporal lobe epilepsy, wherein about 30 to 40% of the patients are refractory to therapy. And recently, a lot of preclinical as well as clinical evidence is available to show that neuroinflammation plays an important role in seizures, and therefore modulating inflammatory signaling might be effective in preventing epilepsy as well as epileptogenesis. So like you can see in this figure that whenever there is peripheral inflammation, it enhances the risk of brain inflammation, which further enhances neuronal excitability and increases the susceptibility to seizures. So if you look at the figure on the right side, you can see that whenever seizures happen, there is an inflammatory cascade in the brain which activates microglia, astrocytes, and there is infiltration of the peripheral immune cells, which then enhances further seizures and inflammation. So it becomes a vicious cycle. And as per the International League Against Epilepsy, it was reported that diseases associated with systemic inflammation, they have been listed among the etiologies that may cause status epilepticus. So now in an actual situation, if you see, a person is exposed to multiple infections throughout the lifespan. And this can result in development of a lot of immune cells. But in the lab, we can mimic this situation by using lipopolysaccharide, which is a bacterial endotoxin derived from the outer membrane of the cell-negative bacteria. And we thought of combining it with pilocarpine. So a systemic inflammatory trigger coupled with a chemical convulsant. LPS is known to trigger toll-like receptors, and it can activate inflammatory signaling. And therefore, when it is combined with pilocarpine, we hypothesize that it can mimic a model of seizures comorbid with inflammation. So like you can see here, we have combined lipopolysaccharide with pilocarpine, and we asked this question whether inflammatory priming before pilocarpine can affect the anti-seizure potential of the conventional anti-seizure drugs or not. So our aim was to first characterize a neuronal inflammation-mediated model of status temporal lobe epilepsy using 3 conventional anti-seizure drugs, which are carbamazepine, sodium valproate, and levetiracetam. And then we wanted to see if the lipopolysaccharide trigger systemic inflammation is able to affect the anti-seizure efficacy. And simultaneously, we also established an in vitro model of neuronal inflammation in the mouse hippocampal cells, wherein we evaluated the cell signaling pathways. So here you can see that in this figure, you can see that we have given a combination of LPS plus Pilo, which has enhanced aggravated status epilepticus. So it has reduced the latency to seizures and increased the severity. And when we checked the effect of conventional anti-seizure drugs, it was very interesting to see that the conventional anti-seizure drugs, they were able to enhance the latency in the pilocarpine model. However, they were not able to protect against LPS plus Pilo model. So like we used the 3 drugs, sodium valproate and carbamazepine. So sodium valproate and carbamazepine were not able to protect against seizures in the LPS preconditioned model. So which indicates that whenever there is overactivation of inflammatory signaling, it can result in loss of protective efficacies of the conventional anti-seizure drugs. And we can also relate it clinically, where generally resistance has been observed whenever there is neuroinflammation. So levetiracetam, however, showed a partial protection in enhancing the latency, but it had no effect on the severity of seizures. So now, generally, status epilepticus result in development of temporal lobe epilepsy. And in temporal lobe epilepsy, there are various cellular changes that take place in the brain, and mostly hippocampal region, CA1, CA3, and dentate hilus region. And we also observed that there was significant neurodegeneration in these regions, and there was significant increase in the percentage pycnosis. Now, what we could correlate was that the anti-seizure drugs, they could protect against this neurodegeneration in the pilocarpine model. However, they were not able to show the effect in the LPS preconditioned model, and therefore this was correlated well with the behavioral seizures. Now we wanted to check if the inflammatory signaling involves NF-kappa B pathway. So we looked at the phosphorylated levels of the NF-kappa B in the hippocampus of animals treated with Pilo, as well as LPS plus Pilo. And here you can see that the anti-seizure drugs in the LPS preconditioned model, they were not able to reduce the elevated phosphorylated levels of NF-kappa B. So, next we looked at the pro-inflammatory cytokines, and we looked at the pro-inflammatory cytokines level in both hippocampus and serum, because serum levels get affected by a number of other factors. So when we checked in the brain, there was elevated interleukin-1 beta, IL-6 and TNF-alpha upon LPS priming, and they remained unaffected by anti-seizure drugs in the preconditioned model, except there was serum IL-1 beta reversal by levetiracetam. Now, clinically, it has been observed that in drug-resistant cases of epilepsy, there has been an increase in the TGF-beta level. So we also looked at whether TGF-beta was playing any role. So there was actually an enhancement of TGF-beta level when lipopolysaccharide was combined with pilocarpine. And again, the increased levels in the preconditioned model remained unaffected by the anti-seizure drugs. So the key findings from this study was that we have established a model of seizures comorbid with inflammation in C57 black mice, and wherein we showed that whenever there is systemic inflammation, it can also increase brain inflammation, and it can reduce the, it can increase the seizure susceptibility, and this further results in loss of anti-seizure efficacy of the conventional anti-seizure drugs. And this was found associated with NF-kappa B, TGF-beta, and cytokine signaling pathways. And this work we reported in neuroscience. And next we moved on to find out that now we have established a model, but we know that the conventional anti-seizure drugs are not effective. So what could be the possible targets? So there came the role of phosphoinositide 3 kinase, which generally gets activated in neuroinflammation as well as in seizures. And herein we showed, so we thought of PI3K as a potential target because LPS also causes activation of this pathway. So we wanted to check. Now, if you look at the downstream of PI3K, there is mTOR. mTOR inhibitor role in seizures is already well reported because rapamycin is also clinically used. And recently there were a lot of reports wherein the role of this pathway was established in multiple types of epilepsy in post-traumatic as well as in PTZ-induced model. So we thought of targeting this pathway upstream of mTOR, which has not been reported. So bupralisib is a pan-PI3K inhibitor, and then rapamycin is an mTOR C1 inhibitor. And then we targeted this pathway at 2 nodes at a time by taking a dual inhibitor of PI3K as well as mTOR C1. So now we wanted to see the effect of these drugs on the mouse hippocampal cells to study the cell signaling pathway, where we optimized the various concentrations and we checked their effect on the cytotoxicity, on the cellular redox, and on the mitochondrial membrane potential. So here you can see that now changes in the mitochondrial membrane potential is one of the first steps which occur after seizures whenever there is neurodegeneration. So there was significant increase in the mitochondrial membrane potential, and this was, you can see that the KES drugs, bupralisib as well as dactylizib, they were able to reduce the potential. However, rapamycin did not show any significant effect. Next we went on to look at the nuclear integrity. Now here also you can see that rapamycin against the pilocarpine model is able to reduce the nuclear damage. However, in the preconditioned model, rapamycin is not able to reduce nuclear damage, whereas bupralisib and dactylizib are able to reduce the nuclear damage in the LPS preconditioned model. So then we went on to see whether what we have observed in the mouse hippocampal cells, whether they are correlating well in vivo in the behavioral seizures. So here we observed that you can see that LPS plus pilo has reduced the latency to seizures, while the bupralisib as well as dactylizib, they are able to show the protection against pilocarpine-induced seizures in the combination as well as in pilo model. However, rapamycin failed to show any protection in the preconditioned model. And this correlated well with the histopathology. We also went on to see phospho-NF-kappa B levels, and to our surprise, all the 3 drugs were able to reduce NF-kappa B levels in the preconditioned model. And then similar way, like we have done for establishing the model, we looked at the cytokine level, and then we looked at the TGF-beta levels, and the TGF-beta levels, rapamycin, now TGF-beta elevation is also seen in patients' brains where drug-resistant epilepsy has been reported. So rapamycin was not able to reduce these TGF-beta levels in the preconditioned model. Now to know the exact mechanism, we looked at the phosphorylated levels of the AKT as well as the S6 kinase, because if you see this figure, now whenever PI3K gets activated, the AKT gets converted into phosphorylated AKT, and then further downstream pathways gets activated. So now the ratio of the phospho-AKT to total AKT can be considered as a biomarker for PI3K activity. However, the ratio of the S6 kinase is a biomarker for the mTOR activity. So we wanted to see what is happening at the pathway level, and what we found was that you can see here the phospho-AKT were not affected by rapamycin. However, again, S6 kinase was reduced by rapamycin in the pilo model, but not in the preconditioned model. And this is because if you see bupralisib is acting on PI3K, rapamycin is acting on mTOR C1. However, it is possible that there is reactivation of mTOR C2, which is further activating the PI3K pathway. So then we also wanted to check whether there is any cross-activation of ERK whenever we are inhibiting PI3K, because it is possible that there might be cross-activation of ERK pathway. And to our surprise, we found a cross-activation of the ERK pathway here. you can see that ERK levels is increased, even though we do not know the significance of the enhanced ERK at this stage, but it is possible that if we use the combination of ERK inhibitors with PI3K in future, it might give us some story as to what is happening. So the key findings from the part 2 of our work was that the PI3K inhibitor and the PI3K-mTOR dual inhibitor were able to protect against seizures. Rapamycin showed resistance in the model, and which could be due to reactivation of the pathway. So this I have explained it here, that when mTOR C1 is inhibited, the mTOR C2 gets activated, which can potentiate the seizures, and therefore we suggest that targeting the PI3K-mTOR pathway at 2 nodes at a time may provide protection against resistance type of seizures where conventional anti-seizure drugs are not effective. And this work was published in Frontiers in Immunology. And I would like to thank my research scholar who has carried out this work, and a part of my funding agency. This work was supported by UGC Special Assistance Program and AICT MODROPS grant. And I would like to thank Jamia Hamdard for the facilities and National Academy of Medical Sciences for giving me this opportunity.
Thank you, Dr. Vora. Yes.
I will request Dr. Phil on that one.
The next oration is also Dr. B.K. Anand oration, but for a different year. And the orator is Dr. Mahendra Kumar Thakur. On the screen, we can see the description of the oration. Can we have the previous slide, please? About Dr. B.K. Anand oration. Yeah. Dr. B.K. Anand oration was instituted in the year 2004 in the name of Dr. B.K. Anand, an eminent neurophysiologist and one of the past presidents of the National Academy of Medical Sciences, by a donation from Dr. B.K. Anand Benevolent Trust. The oration is awarded to an eminent basic medical scientist with special contributions related to neurosciences, alternating with a physician or healthcare professional who has made significant contributions to medical education. And the orator is Dr. M.K. Thakur. Dr. M.K. Thakur is a NASI senior scientist at the Institute of Science, Banaras Hindu University. He is former professor and head Department of Zoology and coordinator of DBT ISLS BHU. His areas of specialization include neurobiology of aging, dementia, Alzheimer's disease, gene regulation, epigenetics, and many others. He has published over 160 research papers and 2 books on molecular and cellular neurobiology and brain aging and therapeutic interventions. Many students have received PhD under his mentorship and guidance, and he is a fellow of NAMS, Indian Academy of Neurosciences, and National Academy of Sciences, India. So over to you, sir, Dr. M.K. Mathur.
Thank you very much, chairpersons, esteemed fellows and members of the National Academy of Medical Sciences, participants and dear friends. It's a great pleasure and proud privilege for me to present today Dr. B.K. Anand oration. At the outset, I would like to express my gratitude to the National Academy of Medical Sciences, particularly members of the award committee and executive committee, to provide me this opportunity to speak today on epigenetic regulation of memory during aging. Memory impairment is a very common problem which is faced by all of us, particularly in old age. And in severe conditions, this becomes very embarrassing and it deteriorates the quality of life. It was believed for a long time that memory lost once cannot be recovered. However, recent epigenetic research has shown that it is possible to recover the decline in memory during aging and other disorders. Before I share our research findings, let me pay my tribute to Padma Shri Dr. B.K. Anand, who was an outstanding scientist and educationist. He is known as the founder of modern neurophysiology in India, and he is famous for the discovery of feeding center in hypothalamus and other path-breaking discoveries, and also his research on yoga and high-altitude physiology. In our laboratory at Banaras Hindu University, we are interested to understand the molecular mechanism of aging and its consequences, and we focus on a vital function of the brain, memory, which declines with age. We use 3 models. One is physiological aging model, in which case in old age memory is reduced. Then we use pharmacological mouse model, where the memory is impaired using a drug, scopolamine. And recently we have been using samples from dementia patients in collaboration with Department of Neurology and Geriatric Medicine of Institute of Medical Sciences at BHU. Today I will be briefly sharing with you about our recent findings on an enzyme, histone deacetylase 2, which plays important role in memory, and I will show you how it influences histone acetylation and gene expression. And we will see that this histone deacetylase 2 increases in old age. So we have tried to inhibit this using some markers and specific strategy. And by inhibiting this enzyme, we have been able to demonstrate that the memory decline can be rescued. So as we know, with advancing changes, there are many cellular, molecular, morphological changes in the brain, and all these changes result in functional deterioration, and one of the functional deterioration is memory. The cellular basis of this memory is synaptic plasticity, and as we know, the brain is made up of billions of neurons, and these neurons communicate with each other through these synaptic connections. And the brain has an amazing capability of synaptic plasticity. So these synaptic connections, they are formed and they are broken during the process of memory formation and loss. And it is this synaptic dysfunction of aging which can be reversed using these epigenetic mechanisms. As we know, this memory involves 3 steps. When the information is acquired through sense organs, that is sensory memory, and when attention is paid, it becomes short-term memory, which upon consolidation is converted into long-term memory. And when this memory is stored, it can be retrieved. And with advancing age, there is problem at all the 3 steps of memory formation. So there is a cascade of pathways, a number of genes, synaptic plasticity genes, which are involved in this process. Particularly in long-term memory formation, there is activation of neuronal immediate early genes, and we have focused on these 4 genes. And because of activation of the genes, some new proteins are formed, and these new proteins help in the formation of synaptic plasticity, a strengthening of the synapses. And when there is any defect in this pathway, then there is problem with the memory, or there is memory impairment. So what we know the external input, that is the sensory information. We know the behavioral output in the form of memory, but the pathway in between is like a black box which is not very clearly understood. And it is not only the aging of the brain, but there are other factors which attribute to the loss of memory, like neurodegenerative diseases, depression, hypoxia, traumatic brain injury, infection, stress, and so on. And as the mechanism underlying this gene expression and memory is not clearly understood, it limits the efficiency of currently available drugs to recover or delay memory decline during aging. So in this context, this epigenetics is very helpful, and in the brain, this is known as neuroepigenetics, and when it is in context of memory, it forms a new discipline of cognitive neuroepigenetics. So this epigenetics is literally means above the genetics, and it regulates the gene activity through modifications in DNA and histone, which is the constituent of chromatin. And it regulates the gene activity through these modifications without altering the base sequence of DNA. So basically, these epigenetics consist of DNA methylation, in which case it is the cytosine base which is methylated to 5-methylcytosine. And then histones undergo different types of modifications through acetylation, phosphorylation, adiporibosylation, and so on. And this acetylation is the most studied modification with respect to memory. And among histones, it is histone H3 at lysine 9 and lysine 14, which play active role in memory formation. And these modifications don't work alone, they work in coordination. So when DNA is methylated at cytosine base, then to this methylated cytosine, a protein known as MECP2, that is methylcytosine binding protein, interacts. And then this protein recruits histone deacetylase 2 and other co-repressors. And binding of this complex at the promoter region of a gene, it inhibits the expression of the gene. And when it is the synaptic plasticity gene inhibited, that leads to cognitive decline. So such epigenetic dysfunction is responsible for memory impairment. And when we play with this epigenetic dysfunction and can repair this, then it is possible to recover the memory. So in our experimental strategy, we have used young adult and old mice, and then we have subjected them to different types of memory. And today I shall tell you here only about one memory test, that is novel object recognition test. And then we have studied the expression of different chromatin modifying enzymes, and we have seen the effect of these modifications on the histone acetylation as well as the expression of neuronal immediate early genes. So this novel object recognition test is a well-studied memory test, in which case the animal is exposed to two familiar objects, and it is the inherent property of these animals that they have exploratory nature, so they would like to interact more with novel objects. So after 48 hours, we replace one of the familiar objects with a novel object which is different in shape and size. And then we allow the mice to interact with these objects. And this interaction is recorded. And then we analyze the data with the help of software. And as you see here in this case, in case of young and adult, the mice are interacting more with the novel object, but in case of old, the animal is spending almost equal time with novel and familiar objects. So when we calculate the discrimination ability for novel and familiar objects, it is seen that this ability is quite high in case of young and adult, but it is diminished drastically in case of old animals. Then we have checked different chromatin modifying enzymes, and as you see here, histone deacetylase 2 expression is increased in case of old, both at the messenger RNA as well as at the protein level. It is not only the expression of this histone deacetylase 2, but also its binding at the promoter of this neuronal immediate early gene is increased. So there is a stronger binding in old age. And as a result of this high expression of histone deacetylase 2 and its stronger binding, there is decrease in histone acetylation in old animals. And it is not only at the level of global level of these histone acetylation, but also histone acetylation at the promoter of these neuronal immediate early genes is reduced in case of old animals, as it is evident from this chromatin immunoprecipitation experiment. With histone acetylation, also the expression of immediate early genes in hippocampus decreases in old for all the 4 genes you see here at the messenger RNA as well as at the protein level, the expression is reduced in old. So as the expression of histone deacetylase 2 and its binding to the promoter region is increased in old age, so we have tried to inhibit in 2 ways. One is the use of SDAC2 inhibitor, that is sodium butyrate, and to have more precise specificity, we have used antisense therapy. And then after this administration of antisense in the hippocampus, we have checked the novel object recognition memory of animal and expression of the genes. And as you see here, in both cases, upper panel shows for sodium butyrate, lower panel shows for antisense therapy. In both cases, the recognition memory is improved, as it is clear from the discrimination ability. Not only the memory, but also this SDAC2 inhibition increases histone acetylation at S3, K9, and K14 at both messenger RNA and protein level, and it also increases the neuronal immediate early gene promoter histone H3, K9, and K14 acetylation by both sodium butyrate as well as antisense. And as a result, also the expression of the genes is increased in case of old age because of inhibition. So in case of young and adult, histone deacetylase is low, so chromatin is open, and it can induce the expression of synaptic plasticity genes, which is responsible for memory formation. But in case of old, this SDAC2 is reduced. As a result, chromatin becomes more compact, and gene expression is inhibited. In case of hippocampal synapses, so memory is impaired. And when this SDAC2 is inhibited, then the case is reversed, all the changes. So it is not only the SDAC2, but also transcriptional co-repressor SYN3A, which is a factor acting with SDAC2. When this is silenced through siRNA therapy, then it also rescues decline in memory. And not only acetylation, we have checked also the histone methylation, particularly histone S3K9 trimethylation. This is negatively correlated with memory. And we have seen that there are several epigenetic modifiers which have potential to act as a therapeutic agent for memory decline. So the take-home message in conclusion is, memory is not erased, but it becomes inaccessible in old age. And animal model research shows that memory loss can be recovered using epigenetic regulators. And when this animal model research is translated to human beings, this will improve the quality of life in elderly. So this work has been done at Banaras Hindu University with the help of a team of intelligent PhD students and generous funding from different agencies, and in collaboration with scientists from India and abroad, and because of superb mentors. And thank you all for presence hearing. And Dr. Sood is standing, so I am closing my lecture.
Thank you, sir. It was very interesting. I think we all need your advice on how we can manage our
I will request you
memory, which is inside, not lost. Thank you.
Thank you. Now the next oration is Dr. Baldev Singh Oration. This oration was instituted to commemorate the outstanding contributions of Dr. Baldev Singh to clinical neurosciences. Dr. Baldev Singh was a founder fellow of the National Academy of Medical Sciences and professor of neurology at All India Institute of Medical Sciences, New Delhi. The National Academy of Medical Sciences, India has instituted Dr. Baldev Singh Oration out of the funds graciously donated in the year 2007 by the Honorable Chief Minister of Punjab at that time. The orator is Professor Pradeep Sharma. Professor Pradeep Sharma is former professor and head of the section of pediatric ophthalmology, strabismus and neuro-ophthalmology at Dr. Rajendra Prasad Center for Ophthalmic Sciences at AIIMS, New Delhi. Director, Strabismus, Pediatric Ophthalmology and Neuro-Ophthalmology Center for Sight, New Delhi. He has many laurels to his credit. He is the first Asian invited to deliver NAP lecture by the American Association for Pediatric Ophthalmology and Strabismus at Vancouver in 2016. He had fellowship for advanced training in strabismus in USA. He is recipient of several awards, some of which I'll name. Achievement Award by the American Academy of Ophthalmology in the year 2017. Colonel Rangachari Gold Medal for the Best Scientific Paper in 1984, and Dr. Athavale Award in 2002 of All India Ophthalmic Society. He was awarded Fellowship of NAMS and named orations of 13 state ophthalmological societies and iFocus H.K. Tiwari Golden Apple 2019. He is a visiting faculty in Orbis, the Flying Eye Hospital 2002. He is international member of several prestigious societies. He has over 250 scientific articles in national and international journals of repute, and he has contributed several chapters in books. And he has authored books named Strabismus Simplified and Essentials of Ophthalmology. So, Professor Pradeep Sharma, sir, please.
Thank you, Professor Vadhva. Thank you for that kind introduction. I would also like to thank the chairpersons on the stage and all the dignified people who are listening, especially Dr. Anita Panda here, and the selection committee for giving me this honorable award, which I really treasure, as Dr. Baldev Singh is very close to our heart. He is known as the grandfather neuron, Dr. Professor Baldev Singh, 1904-1998. He got his medical education from King Edward Medical College, Lahore in 1927, and then he went to London. He returned in 1931, started his practice in Amritsar. The interesting part is, after a very successful practice, he changed his track in 1949, went back to US to serve his other interest of epilepsy and EEG, where he worked, and then he came back to work in CMC Vellore. He was the co-founder of Neurological Society of India in 1951. Now, this is around the age of 50 that he's doing this. He's he was the founder of Neurosciences Department at AIMS and also the Emeritus Professor at AIMS. He received the much coveted Padma Bhushan, which he very well deserved and gave honor to this name. In 1974, when I joined as an MBBS student, we used to see Dr. Baldev Singh in the hostel mess. And he was such a down-to-earth person. He was really a sannyasi. We knew that he was doing research in neurophysiology, but I think his work on yogis was done by an yogi himself. I would also like to thank all the and commemorate the names of previous Baldev Singh orators that are there. Today I'm going to talk on nystagmus. Clinical neurosciences was very dear to Dr. Baldev Singh, and this is a topic which is going to be more clinical. Nystagmus, as you all know, is a rhythmic, regular oscillation of the eyes. It may consist of alternating phases of slow drift in one direction with a corrective jerk movement in the opposite direction. And it may be slow, sinusoidal, or pendular oscillations. I have no financial disclosures to make. It may be classified, as we have done in this book of mine, as physiologic, pathologic, and motor or childhood nystagmus and nystagmoid conditions. Physiologic, as you all know, the optokinetic nystagmus, the common which you observed in the railroad nystagmus, or the vestibular nystagmus seen with the caloric testing or the positional Berenice chair, endpoint nystagmus and voluntary nystagmus. We should also distinguish the nystagmoid movements, which may be in the form of Heyman-Bilshosky's phenomenon or convergence retraction nystagmus or opsoclonus. We know about several acquired nystagmus conditions as neurological lesions which cause them, but we are now more focused on to the nystagmus in childhood, and I would like to say that we need to have these red flags of conditions like spasmus nutans, seesaw nystagmus, and vertical nystagmus, where we need to do imaging. Otherwise, most of the childhood nystagmus do not require imaging. The prevalence is 24 in 10,000 as by a survey in Leicestershire. First, to the sensory nystagmus, which may be having the cause of being an ocular condition which is causing poor vision by itself. Now, this is how it moves, a pendular nystagmus from side to side. And we should look for, in the ocular conditions, the underlying cause which is there. It may be in the retina or the optic nerve. So a good eye examination should be done, and electroretinography and VER will further tell us about the problem. The infantile nystagmus syndrome, which is the most common variety, is the one which we are going to talk more about. It is a bilateral conjugate uniplanar nystagmus which worsens on fixation attempt. And this you can see in the child is there as a side-to-side movement, triangular phase, and then it becomes a jerk nystagmus. It evolves in 3 phases. By the time of 3 or 4 years, the head posture gets stabilized, and this is the time when we have found that we should be operating to restore their binocular position in the center. So this is how an infantile nystagmus would appear with a face turn, like in this case to the right side, because he has an eccentric null position. We should distinguish an adduction null from the gaze null. And as you can see here, covering the right eye in adduction null, the left eye was still continuing to fixate. So this is an infantile nystagmus with an eccentric null. As against this condition in which you will see there is a adduction null in the right eye fixing, and when we cover the right eye, it switches to the left eye. It initially worsens and then the head turns. Now this is a very simple test which will tell you that this requires a different approach, and a bimedial medial rectus Farden is what we suggest. Manifest latent nystagmus, which may be seen associated with squints, is another problem that we have to be aware of as a latent nystagmus. Now here there is an intermittent divergent squint in this lady, and when we cover it with a translucent occluder, once the squint becomes manifest, the nystagmus also becomes more prominent. Now such conditions can be resolved by just correcting the squint which is there. In infantile esotropia, there may be a head turn because of an adduction null, and we correct it, and you can see here the nystagmus as well as the squint both get corrected after a bimedial recession with posterior fixation. Another variety which is important to remember is the spasmus nutans. Now here we have to be very careful. If you find a dissociated nystagmus, that means the 2 eyes are moving at different speeds or different amplitudes. Now these children, we have to do imaging to rule out a chiasmal glioma or an optic nerve glioma. 80% of the cases are benign, but 10 or 15% may have a chiasmal glioma, but there is no clinical way to differentiate, and we need to do this test and save the life of the child. So these cases which we need to differentiate, we have to keep in mind. Another kind of nystagmus that we see in childhood is the nystagmus blockage. What you see here, when the eyes are straight, the nystagmus is visible. And then he has a tendency to lock, and the esotropia comes in, and the nystagmus gets resolved or reduced. Now, these cases we can operate and make the nystagmus corrected by a Farden procedure on the medial rectus. So, just to summarize, examination of the nystagmus, we need to look for the head posture for distance and near, look for associated squint, and any associated albinism which may be there, very commonly seen in the infantile nystagmus syndrome. These we need to see. And we should also see the visual acuity in these children differently, because binocular vision is going to be better than monocular, because the latent component becomes manifested by covering one eye. So we need to always test the vision binocularly also, and then estimate the monocular by using a +4 lens instead of an occluder. Measurement of the null position can be done to correct the head posture, but mind you, keep in mind that some of the children may have a periodic alternating nystagmus, which requires a different surgical procedure, a bilateral augmented Anderson's procedure. How do we manage them non-surgically? Optimally, we can give the full correction of glasses, use of tinted glasses if there is an albinism, if these children have. Contact lenses are helpful if there is a high refractive error. Prisms based out have been used, but not of much benefit. Auditory biofeedback and acupuncture studies we did in and published in JPOS and in the JCDR recently. On acupuncture also we have seen what happens. Now the study on the biofeedback, Dr. Baldev Singh himself had a lot of interest in biofeedback. Now this is a study done in collaboration with IIT when we changed the nystagmus thing into the auditory biofeedback, and that appeared to resolve the nystagmus, but this is a transient phenomenon. It doesn't have lasting effect. This is only ongoing process. Acupuncture similarly was seen by using the sternocleidomastoid acupoints, and we found that it also dampens the nystagmus, but this has to be kept on twirling the acupoints all the time. It doesn't have a lasting effect. Medical treatment in the form of baclofen, gabapentin, and brinzolamide have been tried, but they do not have much role except for baclofen in the acquired PANs and gabapentin in some infantile nystagmus cases. Coming to mainly the surgical role, we have the 5 strategies that we do. One is shifting the eccentric null. As I had shown you that there is an eccentric null in many of these children, and if we can identify that, we can shift it by a extraocular muscle surgery and give the benefit to the child to have a straight head as well as improved vision. Another strategy is artificial divergence. That means we weaken the medial recti either by a recession or a posterior fixation suture, and that dampens the nystagmus by inducing convergence. Third mechanism is correcting the associated strabismus, and that has been found to be very effective in strabismus-associated latent nystagmus. The fourth strategy is 4 horizontal muscle recessions, which dampens the nystagmus, but we have seen that this effect lasts only for about 3 months. And Hertel-Deloso procedure is another procedure which has been talked about. But the most gratifying surgery is the null shifting procedure, which is done around the age of 4 years, and this can reduce the nystagmus. As you can see here, this child, the head posture has been corrected, and this is after the effect of augmented Anderson's procedure, which we had published in 2006 in JPOS. And these are the electronystagmography features which are improved after the surgery. We have to be aware of this problem of reversal of head posture in PAN, periodic alternating nystagmus, after this procedure. So an augmented Anderson's, you can easily do the other 2 muscles and the PAN can be corrected. So this is what we recommend for most cases. If there is any associated strabismus with a nystagmus, we need to take that into account in the same surgery. And we have to see that the nystagmus surgery is always done on the dominant eye, whereas the strabismus surgery can be done on either of the eyes. A vertical chin down or chin up position can be similarly corrected, as well as the head tilt positions are also corrected by the surgical approach. 4 muscle surgeries, as I said, we published in JPOS in 2016. We found that the supramaximal recessions are effective, but about 3 months role they have. Similarly, the Hurtel-Deloso procedure, which has been talked about much in US, but it has a limited role for 3 months. So, artificial divergence surgeries are helpful in some cases, but we have to be aware of this, that it can create unfusible exotropia. So finally, to summarize, the take-home points are, we need to have an optimal optical correction with glasses. And in albinism, we need to give photochromatic glasses to correct their glare problem. Contact lenses are helpful in high refractive errors. Cases with definitive eccentric null up to 30 degrees respond very well to the augmented Anderson's procedure. For more than 40 degrees nulls, we add resections of the opposite muscles. For periodic alternating null nystagmus, we do a bilateral augmented Anderson's. And for the fusional maldevelopment nystagmus, which I had shown the latent component, we do the correcting the squint surgery. The other problems like Chiantia syndrome or IENA syndrome or nystagmus blockage syndrome, as I had shown, can be improved by medial rectus recession with posterior fixation. We have seen that auditory biofeedback, acupunctures, the 4 muscle supramaximal recessions, and Hurtel-Deloso procedure may be done, but their role is having a limited role for about 3 months. And just to emphasize that imaging should be done in all acquired nystagmus, which have oscillopsia to present with, spasmus nutans, which have a dissociated nystagmus, or if there is any vertical or a seesaw nystagmus. I would like to thank all my patients, my students, my residents, my family, who have given me this calming mind so that I can calm the visual storm in the eyes of the children. Thank you all for a patient listening.
Thank you very much, sir, for this wonderful oration. And we all know Professor Baldev Singh, sir, because of his association with AIMS, and we are also associated with AIMS. Thank you.
So next presentation is online by Dr. Subhashini Sharma.
Next one is online. And do we have Dr. Subhashini online?
Yes.
The next oration to be delivered now is Dr. S. Janki Memorial Oration, which was instituted by National Academy of Medical Sciences in the year 2013. Dr. S. Janki is a distinguished fellow of the National Academy of Medical Sciences and founder of Professor of Neurology at GB Pant Hospital and Maulana Azad Medical College, New Delhi. For this oration, the orator must have original contribution to the practice of neurology, especially pediatric and adolescent, including, amongst others, basic research towards understanding the mechanism of neurological disorders in children, their pathophysiology, clinical or laboratory diagnosis, medical or surgical management, and prevention of such neurological disorders at the individual or at community level. The oration is being delivered by Dr. Subhashini Sharma, who is currently working as a teaching faculty at Kalavati Saran Children Hospital in New Delhi. I can see that Dr. Subhashini Sharma is a graduate of Lady Hardinge Medical College and also completed her MD from Maulana Azad Medical College. Subsequently, she came to do her DM at AIMS New Delhi. She has a special interest in infantile spasm, movement disorders, neuroimmunology, and for which she has been awarded ICMR International Fellowship Award. I can also see that she has worked at Children's Hospital in Westmead, Sydney, under mentorship of Professor Russell Dale. And I can just say that I also worked in Westmead Hospital, Maine, and I used to live in front of the Children's Hospital. So I can see that she is quite. Oh, yes. So, and it is just a coincidence that Dr. Vadva also worked in Westmead Hospital. So we welcome you, Dr. Suhasini, and we look forward to your oration. You have 15 minutes altogether.
Thank you, sir. Is my screen visible?
Yes, very much.
I thank the chairpersons for the kind introduction. I thank the National Academy of Medical Sciences and the selection committee for awarding me this oration and giving me this opportunity to share my work. I will be talking about the dietary therapies for epilepsy in low-resource settings, the challenges and successes. So I'll talk briefly about why we need dietary therapies for epilepsy, especially in low-resource settings, the challenges that we face, and what possible solutions that we have worked out. So basically, I'll talk about what is ketogenic diet. A ketogenic diet, now everybody knows it's used so much for weight loss. Basically, initially, it was started for the use of epilepsy. It is a high-fat, low-carbohydrate diet which has been used for over a century for the treatment for epilepsy. And in the beginning, like the work started in 1921, 2021. From 1920s to 40s, it was the only treatment available for epilepsy apart from bromides. And once phenytoin was discovered in 1939 and other anti-seizure medications came across like sodium valproate, next 50 years, it completely went into obscurity. And for the last 25 years, there's been a major resurgence. And it has been said that it is the ultimate comeback story in the modern era for the treatment of epilepsy. And it is now the accepted treatment option for refractory non-surgical epilepsy. And the summary of its response is that children with refractory epilepsy who try this diet will have a better than 50% reduction in seizure in 50% of the patients, and 10 to 20% of them have seizure freedom. And this response rate is probably better than most anti-seizure medications. There are now less restrictive variants available, like modified Atkins diet and low glycemic index treatment. And this diet is now tried not only for epilepsy, but for brain tumors, Alzheimer's, autism, ALS, Parkinson's, and many non-neurological conditions even, like acne and PCOS. So, starting with the epilepsy in low-resource settings, 50 million people with epilepsy live worldwide, but out of these 40 million are in low and middle-income countries. About half of these are children, and India has less than 200 child neurologists with various levels of trainings for this population of 1.3 billion. And there are numerous treatment gaps. So our etiology in low-resource settings differs from the West. In the West, it's mostly mesenteric sclerosis, tumors. Our main etiology in pediatric age group is perinatal injuries, brain injuries, especially asphyxia and unit hypoglycemia, and infections. So our major players in asphyxia and unit hypoglycemic brain injury, which is the most common cause of refractory epilepsy in our setting. And in low-resource settings, everything is difficult, even anti-seizure medications. In this study, they mapped the availability and price and affordability, and what they found was that, sadly, the highest prices for anti-seizure medications were observed in the lowest income countries. So the situation is much worse for the newer anti-seizure medications like vigabatrin, levetiracetam, topiramate, ECTA. So drugs are very difficult in low-resource countries. Epilepsy surgery is a very important treatment option for refractory epilepsies, but this is very high cost and very few government-funded centers available. The waiting list is very long. And many children with perinatal brain injury, which is a very common cause of refractory epilepsy, may not be good surgical candidates because they have bilateral lesions and multifocal lesions, so it's difficult to plan surgery in them. So the diet may be a good option because it is food after all. It does not require high-tech equipment. It is effective for a broad range of refractory infantile and childhood epilepsy syndromes, especially West, Dravet, myoclonic, astatic, and Lennox-Gastaut, and which comprise a high proportion of children with refractory epilepsy in low-resource settings. I will now talk briefly about my work on the introduce my journey with this treatment for the last 15 years. I joined AIMS 2016 DM Pediatric Neurology. It was one of the earliest candidates. This program was started in 2004 under the mentorship of Dr. Veena Kalra. And we discussed this article in a journal club as soon as I joined. It was 2 ways of starting the diet, and I became interested in this treatment. And Dr. Kalra encouraged me to work this up for my DM thesis. And at that time, literature reviews showed that there was no study from India. Only one center in Mumbai was practicing this. And prior experience in our center was that most people use fasting to start their diet because fasting leads to ketosis, but our patients and parents do not tolerate fasting. So, plus the diet was considered fatty and Western. There was no experience in North India. You need to have complete labeling of foods, which is limited availability. Most of our food is available in open situations. And there's a lot of cynicism there was from medical fraternity, paucity of trained dietitians, because the diet calculation is very tedious and time consuming. It takes a lot of time when you need trained dietitians to do this. And Indian food, as we know, is very rich in carbohydrate staples, especially rice and chapatis, pulses. And whichever part of India we go, one thing is common is that our diet is very, very carbohydrate rich. And the ketogenic diet, you need more of fats and proteins. This diet is going to be 70-80% of the calories has to come from fat. And this is very difficult with an Indian diet. Another problem we face is vegetarianism. Because vegetarian diets, it's very difficult to have that amount of fat and protein. So again, very difficult for Indians to do the diet. The other challenges are that a lot of precision is required, and the heavy fat cream, which was, these are the books I read at that time to start the diet, they said 36% heavy cream, which is not available at all in India. You need digital weighing scales, keto sticks, and the literacy level of the parents to understand these complex instructions. Despite these challenges, and of course we have massively overcrowded hospitals, no special kitchen facilities in the government hospitals for parents to train and cook. So despite these, we went ahead and we first used a non-fasting approach for our patients. And we admitted the patients initially. This was one of the first studies where this was a study of 25 patients on the ketogenic diet. And they were started on a non-fasting protocol. And what was very reassuring was that our seizure control on follow-up was equivalent to the Western studies, that 49% of patients had better than 50% seizure reduction, though there were a lot of side effects. And what we found was that the classic ratio, which was invoked at that time, a 4:1 ratio, that 4 of fat and 1 of carbohydrate was protein, was difficult, and there were tolerability issues and side effects. And of course, our dietitian was very overworked, a lot of tedious calculations. Bed availability was an issue. It was difficult for parents with low levels of literacy, and storage issues for fat between travel, villages. All this led to a high dropout rate. In the meantime, there was studies coming up from Korea, where they compared a lower ratio diet. A lower ratio means we can go up more on the carbohydrates, and they found the lower ratio was equally effective. And we had data published from Mumbai, from Dr. Nathan's group, wherein they used lower ratios, and they found that lower ratios were, they did not compare, but they found the lower ratios efficacy was similar to Western data. So the next study from our group, Dr. Raju's DM thesis, wherein 4:1 ratio was compared to 2.5:1 ratio, and 2.5:1, both the groups had similar improvement in seizures and no significant differences in biochemical parameters. So we can use a lower ratio. This was one of the findings that we did, that we can lower down the ratios with equal efficacy and increasing the carbohydrate and making the diet more palatable for the children. So around this time, the modified Atkins diet, the Atkins diet had been around for quite some time for weight loss. So basic theory of Atkins diet being that instead of reducing fat in the diet, you reduce carbohydrate in the diet. And Atkins diet also led to ketosis. So some patients started using the diet for epilepsy as well. And Dr. Eric Kossoff from Johns Hopkins pioneered the use of this diet for epilepsy. So in this basically, only thing you measure is the carbohydrates. You restrict carbohydrates to 10 grams per day. Fats are actively encouraged and proteins are unrestricted. The way to do it in the West was that parents would just read this book, and they had so many options available in the market of various Atkins foods already there. So it was pretty easy for them to do. So it was an easier alternative, no protein restriction, easier for the doctor, dietitian, with significantly reduced counseling time. But we had to modify it because our patients, we cannot expect them to read this book, and there are no Atkins patients available at least that time. So we followed the basic principles of Atkins that carbohydrates were restricted to 10 grams per day and divided into 4 2.5 gram exchanges. And patients were provided list of free foods, fats were actively encouraged, and soya products for vegetarian population was used. We basically provided them an instruction, general instructions, and around 30 recipes, out of which they could choose any 4 per day and free foods. So this was then evaluated in a randomized controlled trial. One group got the diet and one group was the control group, which is both groups continued their anti-seizure medications unchanged. And at 3 months, we found that proportion of children with better than 50% seizure control is 52% versus 11.5% of the control group, which was definitely significant. And this was similar to the randomized controlled trial of the ketogenic diet. We also demonstrated the efficacy of this diet in Lennox-Gastaut syndrome, which is a very refractory epilepsy, and infantile spasms refractory to first-line treatment. So in 2010, I moved to Kalavati Saran Children's Hospital. Again, similar, it's also a government hospital. We always status lower. It has a long history of pediatric neurology services. Dr. Pradeep Sharma mentioned Dr. Baldev Singh. He started our epilepsy clinic. It's going on since 1958. And we have again a very heavy epilepsy load. And I was working under Dr. Anija, who again encouraged me to continue the ketogenic diet work in this hospital. And we published our work, Modified Atkins Diet in the West is mainly used for older children and adolescents and adults. We demonstrated that it was pretty effective even in the younger children. And we also conducted this study for comparing a randomized controlled trial of this use in epileptic spasms refractory to hormone therapy. And we found that the patient in the diet group had a much better spasm freedom rate compared to children in the control group. And so far, there's been no studies of the drug comparing of the diet compared to the drug. We recently concluded this study where we compared the modified Atkins diet with levetiracetam, which is broad-spectrum anti-epileptic drug. And we found that proportion of children with seizure control was significantly higher in the modified Atkins group as compared to the levetiracetam group. So there are certain problems we have faced with the Atkins diet. It still requires some weighing of foods, the way we have done. It requires parents to be educated. It's very restrictive for vegetarians. It's problematic for older cognitively normal children. There's no scope for basic staples for Indian diet in this, like chapati, rice, and pulses. So for parents with low levels of DIT, we found that parents were motivated, but they couldn't understand the weighing instructions. This was an ICMR-funded study where it simplified it further, the modified Atkins diet, and instead of using weighing, we gave them these metric tablespoons, and they could measure, and they were provided simple pictorial instructions. This was the team with Dr. Anija and our dietitian Shefali and a social worker. And with this weighing metric tablespoons, they concluded the diet. And we found that this simplified modified Atkins diet, this was evaluated in a randomized controlled trial, and children in the diet group had 56% of them had better than 50% reduction in seizures compared to 7.5% in the control group. So again, this was proof that it can be simplified, it can be made. So as long as the parents are motivated, this diet can be used. So people sometimes ask that is the cost of food an issue? And this simple analysis was done by one of my friends and colleagues from Pune, Dr. Umesh Kalane. So this diet cost of an Indian healthy 10-year-old boy was around 90 rupees per day. And for the ketogenic diet, it was 85 rupees per day. So the diet doesn't really, the cost is generally doesn't matter because it's usual home available foods which can be modified. If you tell them something very exotic and they have to buy, it will be difficult for the parents. So we usually modify it from their routine home available foods. So now there are guidelines on minimal requirements for diet in resource-limited settings. So physician is of course mandatory, preferably a neurologist. Dietitian is mandatory for the classic diet, but optional for alternative diets. Because trained dietitians availability is very, very difficult. And we can do outpatient basis, outpatient initiation, except for infants. And lab work doesn't need to be very detailed, basic lab work is enough. So current situation in India, we are so much better than when I started in 2006. There are now 30 centers which offer KD and much better awareness of the diet, and especially amongst general publishers and dietitians. And the PubMed result of diet in epilepsy, ketogenic diet epilepsy in India reveals 41 results, which are we are way ahead. So the way forward is, of course, training can be done. The COVID pandemic has taught us that we can do virtually training, more dietitians can be trained. Early use of the diet, telemedicine can be used for the delivery of the diet, increased use of diet epilepsy. And if we have a lot of demand for keto products, so more suppliers of competitive cost benefits. And of course, we need to talk more about insurance coverage of the keto products and reimbursement. This is still not there. We need parent support groups and networking, knowledge and information sharing. So to conclude, dietary therapies are an important option for children with drug-resistant epilepsy in low-resource settings and possibly superior to the add-on new drugs and neonatal nerve stimulation, appropriate for severe epilepsies caused by perinatal brain injuries. They can be tried while pending epilepsy surgery workup or if no epilepsy surgery facilities are available. The challenges are the need for trained personnel, cultural issues, familiarity, and high-cost formula. Solutions can always be found with the physician and the family and dietitian available after activated. And we need partnership between the doctors, dietitians, and families, simplicity, flexibility, and innovation. I wish to thank my mentors, Dr. Veena Kalra, Dr. Aneja, and I have got a lot of help from Dr. Nathan and Dr. Eric Kosa from Johns Hopkins, my other team members, and all patients and families who let me be a part of their keto journey. And I must thank my family for all their support and encouragement and love. Thank you so much.
Thank you, ma'am. I think it was a wonderful insight into your work, particularly ketogenic diet. We appreciate your contribution and we like to digitally give you a certificate which will be physically sent to you to your address. Thank you, ma'am.
Thank you, sir. Thank you, sir. Thank you.
There is also some money here.
Thank you, sir. Actually, the last speaker is, we are not able to contact him. He is actually supposed to be online. So we are trying to contact him. So are you able to succeed? This is the last one, sir.
Thank you, sir.
Now we are coming towards the end of the orations related session today, and we have the last oration, which is Dr. J.S. Bajaj oration. This oration was instituted in the year 2015 to commemorate the exemplary research work contributions of Professor J.S. Bajaj sir in the area of diabetes mellitus, and this is to be delivered by an orator on the outstanding research work done by him or her, especially related to type 2 diabetes mellitus and its vascular complications, with special reference to etiology, pathogenesis, clinical or laboratory diagnosis, therapeutic management, and prevention at the individual or at community level. And the orator is Dr. U.N. Das. He is a consultant physician, diabetologist, clinical immunologist, and rheumatologist. He has vast experience at different institutions in the country. He is a graduate from Andhra Medical College, Visakhapatnam. He did post-graduation, Osmania Medical College, Hyderabad, that is MD in General Medicine. He is Fellow of National Academy of Medical Sciences, since 1992, Fellow of Royal College of Chemistry, London, 2013, and Mangalore University, Mangalore, 2018, conferred DSc on him. He is a physician and scientist, and he has performed translational research in cancer, diabetes mellitus, lupus, coronary heart disease, atherosclerosis, sepsis, and radiation protection. His studies have led to a deeper understanding on the role of essential fatty acids and their metabolites, prostaglandins, leukotrienes, thromboxanes, lipoxanes, etc. He has published more than 550 manuscripts in international journals, edited 3 journals, published 4 books, and obtained 5 USA patents, and edited 2 books on autism. He has guided 16 PhD students and many MD students. So over to you, Professor UN Das, sir.
Hello, are you able to hear me?
Yes, sir, we can.
Okay. Are you able to see the slides also?
Not now. Start, please, then we will. Please share the slides that you have.
Yeah, I have to sharing. Now?
Yes, sir, now we can see. You can make
Okay,
it full
thank you very
screen.
much.
You can expand it
Yeah.
to make it full screen.
Yeah. Trying to see.
At the bottom right, there is a symbol.
Yeah, I
Sir.
know.
Yes, sir.
Right. I'm not able to see that. See full screen outline.
Okay, if you wish to. It is possible through the top bars also, but the easier way is at the bottom right.
Yeah, I know. That's what I'm looking at in the bottom. You know.
Share the screen and view.
అది కాదు ఫుల్ స్క్రీన్ రావట్లేదు.
On full screen, we find a view.
Yes, sir. Where the cursor is at present. Yes. Thank you.
Okay. Thank you very much.
Sir, you have about 15 minutes to complete the presentation.
Yeah.
Sir. Thank you.
Thank you very much for your kind introduction, and I'm going to talk to you today about our identification of endogenous bioactive lipids which have anti-diabetic properties. The summary of my talk will be that we have identified 2 lipid molecules which are very potent anti-diabetic molecules, both type 1 and type 2. And they are, one is arachidonic acid, and other is its metabolite, namely lipoxin A4. Both arachidonic acid and lipoxin A4 have potent anti-inflammatory actions, cytoprotective actions, and they can enhance the expression of glut receptors and suppress the expression of NF-kappa B and decrease the levels of IL-6 and TNF-alpha. And that's how they are able to produce their anti-diabetic actions. The advantage of the arachidonic acid lipoxin A4 is that they are present in almost all tissues in the body, and that's why they are very highly suitable for this purpose. So to inform, our diet contains mainly the N6 and N3 fatty acids, and the N6 fatty acid is the cis-linoleic acid, 18 carbon and 2 double bonds, and alpha-linoleic acid, which is 18 carbon and 3 double bonds. Both are ALA and ELA are called as the essential fatty acids because our body cannot make them, and we have to obtain them in our diet, and they are very widely distributed in our diet. Their importance lies in the fact that they are converted into their metabolites, namely gamma-linoleic acid, dihomo-gamma-linoleic acid, and arachidonic acid in the body by the action of delta-6 and delta-5 desaturases. Similarly, ALA is converted into EPA and DHA by the same set of enzymes. The importance of these fatty acids, especially AA and EPA and DHA, lies in the fact that they form the precursors to several pro-inflammatory molecules and also anti-inflammatory molecules. So now we believe that this balance between the pro and anti-inflammatory metabolites formed from AA and EPA DHA is important in the pathophysiology of many diseases. Initially, when we started this work back in early 90s, we measured the plasma levels of plasma, hepatic, and muscle levels of these fatty acids by using gas liquid chromatography, especially in animals which have been induced to develop type 1 and type 2 diabetes, type 1 by alloxan and type 2 by giving streptozocin. So here is a slide showing the, which is highlighted, which shows that the arachidonic acid 24 levels are decreased in alloxan treated animals which develop type 1 diabetes. And when these animals are treated with insulin, the arachidonic acid levels come back to normalcy, suggesting that one of the mechanisms of action by which insulin probably decreases the hyperglycemia is by its action on the arachidonic acid, and we have more proof for the same. There are not much changes in the N3 fatty acid metabolites, especially EPA and DHA. And of course, initially we started our studies with using different oils, which contain many fatty acids, like for example, evening primrose oil, borage oil, and darisk oil, which is very rich in arachidonic acid. 40% of it is nothing but arachidonic acid. All these oils prevented type 1 diabetes in Mr. rats. And then we wanted to see which component of these oils is responsible for the anti-diabetic action. So we next did the studies with pure individual fatty acids in alloxan-induced type 1 diabetes and subsequently in streptozin-induced type 2 diabetes. This is a slide showing that when you give alloxan, there is a decrease in cell. So we've initially performed in vitro studies using ring cells, rat insulinoma cells, and we have shown that alloxan and streptozocin decrease the viability of the cells, whereas when you give arachidonic acid, the viability of the cells is increased, suggesting that they have cytoproduct action. Then we checked the individual fatty acids on the incidence of type 1 diabetes with various fatty acids, and we have shown that of all the fatty acids, it is arachidonic acid which is the most potent, which decreases the incidence of diabetes by more than 100%. So it is very, very potent. And then, of course, we did an in vivo study using the animal model of alloxan-induced type 1 diabetes model. And when we inject the alloxan, the glucose levels go up to almost 300 to 400 milligram %, and the insulin levels also drop. Whereas when we give the arachidonic acid, the diabetes is completely prevented. So we have shown in summary that all the PUFAs, especially AA, is the most potent in preventing the type 1 alloxan-induced type 2 diabetes, both in vitro and in vivo. And AA restored the antioxidant status, the data which I have not shown. Then we want to look at the mechanism. So we studied the cyclosidase and lipoisidase inhibitors, which did not prevent the anti-diabetic action of arachidonic acid. And subsequently, we tested several prostaglandins and thromboxanes and leukotrienes. They also did not prevent the alloxan-induced diabetes, suggesting that AA by itself is able to prevent the diabetes or some product other than prostaglandins and leukotrienes. And then, of course, we know that type 2 diabetes is most of the peripheral insulin resistance. And then we tested the type 2 diabetes animal model also in streptozocin-induced model and also in high-fat diet model. And then also we found that arachidonic acid is able to prevent both type 1 and type 2 diabetic model. And then we did further studies to see whether lipoxin A4 has a role, because prostaglandins and leukotrienes do not have a role. And then we did this study, and then we found that lipoxin A4 is formed when arachidonic acid is given, and that's how arachidonic acid is able to prevent the development of both type 1 and type 2 diabetes. And then, of course, this data we have published subsequently. And thus, there is some amount of discrepancy between in vitro data and the in vivo data. In vitro, other fatty acids are also able to prevent, but it is only the arachidonic acid and lipoxin for which are able to prevent diabetes. Then we checked whether alloxan and streptozocin interfere with the formation of lipoxin A4 from arachidonic acid. This is a slide showing the formation of lipoxin A4 when the ring cells are treated in vitro with streptozocin. You find that with increasing dose of streptozocin, there is decreased formation of lipoxin A4. And then, of course, then we checked whether the ability of other fatty acids, all the fatty acids, to increase the lipoxin formation. Of all the fatty acids tested, again, it is only arachidonic acid which is able to increase the formation of lipoxin A4. And thus, we found that both alloxan-induced and streptozocin-induced diabetes of both type 1 and type 2 is due to decreased formation of lipoxin A4, and arachidonic acid feeding or injection is able to restore the lipoxin A4 formation to normal levels, and so it is able to prevent the diabetes. Then, of course, we looked at the mechanism, and we found that both arachidonic acid and lipoxygen F4 are able to suppress the expression of NF-kappa B, and that's how they are able to produce their anti-inflammatory action and prevent the development of both type 1 and type 2 diabetes. And then, of course, in the animal model, we have shown that streptozin in type 1 diabetes, the insulin secretion that is decreased, it can be restored to a large extent by arachidonic acid and lipoxygen A4. And of course, we measured the plasma lipoxygen A4 levels, and we found that the lipoxygen A4 levels remain, come back to almost normalcy in the treatment of AA. And when we give lipoxygen A4 also, the plasma levels of lipoxygen A4 will come to near normal levels. So these results show that AA can prevent streptozin and orexin-induced type 1 diabetes mellitus. Arachidonic acid treatment restores plasma glucose levels, insulin, and TNF-alpha levels to normal. And both streptozin and naloxone, they inhibit lipoxygen formation. And AA treatment restores the lipoxygen levels. So AA seems to possess antidiabetic action by its ability to enhance lipoxygen formation. Then, of course, we did the type 1 diabetes animals model, again with lipoxygen F4 to reconfirm these results. And we found that lipoxygen F4 can prevent the development of type 1 diabetes. And of course, it also restores the plasma insulin levels. And then lipoxygen F4 is such a potent anti-diabetic molecule, at least to prevent both type 1 and type 2 animals. And then that is also because of its ability to reduce the plasma TNF-alpha levels and also IL-6 and suppress the expression of NF-kappa B. So thus, similar to AA, lipoxygen F4 are also inhibited naloxone and streptozin-induced type 1 diabetes, restored plasma glucose levels, and then have shown potent anti-inflammatory actions. Then, of course, we looked at the comparison. This is a comparison showing the NF-kappa B expression in type 1 and type 2 animal models and how they can be restored by the lipoxygen F4 and arachidonic acid. So both AA and lipoxygen F4 are anti-diabetic in nature. They are present in our body tissues. They are in the circulation. And AA protects beta cells both in vitro and in vivo, and both against naloxone and streptozin in diabetes. Then subsequently, we also looked at high-fat dieted animal models also. There also it prevents. And AA product lipoxygen F4 seems to be the mediator by which arachidonic acid prevents the diabetes. And lipoxygen F4 also prevents by itself. But lipoxygen F4 is unstable, and so we cannot use it, whereas arachidonic acid is a stable fatty acid that can be used very easily, and it can be given even orally also. And then, of course, then we wanted to see whether this happens in the patients with diabetes. This is a slide showing the measurements of plasma levels of arachidonic acid and other fatty acids in patients with hypertension, diabetes, and coronary artery disease. We find that in patients with type 2 diabetes, the arachidonic acid levels are reduced by almost 30 to 40%, and showing that type 2 diabetic patients have arachidonic acid deficiency. Then we measured the lipoxygen F4 levels in the plasma, and we have shown that lipoxygen F4 levels are also reduced in patients with diabetes. And so this confirms the animal studies we have done, showing that arachidonic acid and lipoxygen F4 levels are decreased in patients with type 2 diabetes. And so restoring their levels to normalcy will prevent both type 1 and type 2 diabetes. So in summary, we have shown, we have identified that AA and lipoxygen F4 prevent both type 1 and type 2 diabetes in animal models, and they are low in patients with type 2 diabetes. And AA and lipoxygen F4 have potent anti-inflammatory actions. And the most important thing is, orally AA is effective in preventing the in diabetes and also in restoring the lipoxygen F4 levels to normalcy. And so now we are performing clinical studies to look at the effect of AA in preventing the type 2 diabetes in humans. Thank you very much. And this is the group of my PhD students who have performed this study, and they have done wonderful work. And this work was supported by DST, ICMR, and other funding agencies. Thank you very much.
Thank you very much, sir, for this wonderful oration. And this has been very informative. You have shared your lifelong experience of research work. And on behalf of National Academy of Medical Sciences, I am very glad to present the scroll and the check although through the virtual medium. In the physical form, it will be ensured that it reaches you by the office of the NAMS. Thank you.
Thank you very much.
Thank you, sir. Thank you so much. And we are coming to the end of this particular function. So before I conclude, I would like to thank the chairpersons, Dr. O.P. Kharpanda, Dr. Sanjay Vadva, and Colonel Velu Nair, who had been with us throughout the day. Thank you so much, sir, for conducting this function. We are really grateful to you. And we invite all of you for the next function, which is going to start in another half an hour. So please have a cup of tea outside and then please come inside. Thank you so much, sir.
Aipai Lakshmi.
Welcome everyone. We are having a special program on inaugural NAMS public oration on law and medicine, and this occasion becomes even more special and important because we have the renowned people from medical fraternity, experts, and all our special guests. The eminent guests and the dignitaries are about to arrive of the program today. Please put your hands together to welcome the special guests. Chief Justice of India, Justice N.V Ramana, Shri Rajesh Bhushan, Secretary, Ministry of Health and Family Welfare, Professor Atul Goyal, DG Health Services. All our special guests will be present in this program today. And on behalf of National Academy of Medical Sciences, I welcome all of you to this special program, Special Evening. We'll be starting the proceedings of the program. May I request Dr. Shiv Kumar Sareen to accompany the dignitaries to the stage. Honorable Chief Justice of India, Justice N.V Ramana. Please put your hands together to welcome the chief guest. Shri Rajesh Bhushan Ji, Secretary, Ministry of Health and Family Welfare. Together to welcome the special guests. By National Academy of Medical Sciences, it is a premier academy of medical professionals in the country. NAMS is an organization of acclaimed physicians, academicians, researchers in medical sciences. और कहते हैं कि परिंदों को मंजिल मिलेगी, ये फैले हुए उनके पर बोलते हैं, अक्सर वो लोग कम बोलते हैं, ज़माने में जिनके हुनर बोलते हैं. The important initiative of National Academy of Medical Sciences include constituting 21 task forces, out of which 6 are actively working. It includes fellows of NAMS are amongst the most distinguished medical professionals in the country. It has members from Ministry of Health and Family Welfare. It has
Thank you, sir. It tells us, gives us confidence that there is certainly a point of convergence, and with your blessings, I'm sure doctors would feel much more happy, much more privileged. Sir had held both. Sir, I will have few requests to you, if you permit. All decisions with that in mind is put to violence, face violence, and have issues of safety. I know, sir, you and the Health Ministry has made several laws, but I wish they had more teeth, so that our fraternity, including me, will feel safe. So my first humble request is in medicine. My second request to you, sir, we have several Indian Administrative Service, Indian Foreign Service, Medical Service, and Indian Medical Service, especially during emergency times, needs to be fulfilled. So, and I think there should be a way by which doctors are part of a regular organization. The third humble request is, if there are cases of negligence or if there are cases where doctors are involved, the amicus not merely be an outsider. It is a reason behind it, because to understand, when I am doing a procedure, believe me, and you have to put in a hole and take a biopsy, your coronaries are shrunk like this. It is worse than launching a Sputnik. 1 millisecond mistake and you are this side or that. And the error of judgment versus negligence I'm sure you will differentiate it, sir, but error of judgment is not negligence. So I would request that this point may in your fellow judges must somewhere be reflected. I'll come to the NAMS and the public oration. We have tried through you, sir, to initiate a public oration. And just when I mentioned the Honorable our Secretary Health and also the Director General, they were very happy. They first wouldn't believe that CGI has agreed to come. And since you are coming, I must say the Secretary Health was here at 5 national policy initiative. And the Secretary Health had blessed us that yes, you grow, give us the technical guidance. So NAMS is indebted, sir, to you and to the DGHS for these guidances. Sir, NAMS, I tell you, when I came, I was privileged to work in this, and I have Professor Dave with us today, who was the past president of NAMS. It's a privilege to have worked in this initiative. To thank each one of you for having come here. We would like to assure you that we would be there if you people give us the guidance. The public lecture is an open invitation to public to guide us. What do people want from doctors? What do people in public think of them? Do we not regulate ourselves? Do we not make our own life more ethical? I sometimes ago, sir, coined a term which you might find new, it's not in the dictionary, called Bethicalism. Bethicalism is a term, B-E, ethicalism. Every religion, let it be Jainism, Judaism, Hinduism, core is ahimsa, core is treat others as you treat yourself, like to be treated. Bethicalism, be ethical. And be ethical, I think, is same as in law. What is law? It is actually, in my limited knowledge, is like giving you the righteous judgment. So whether it was Buddha, whether it was Mahavira, whether any of those people, I think being ethical, and I would request all of us, including me, to be ethical so our professions can stand up against any scrutiny.
Every individual needs to play an active and important role for staying healthy and can contribute to the development of the country. May I request the guest of honor, Professor Dr. Atul Goel, to enrich us with his wisdom words. Dr. Goel, please.
Thank you, Honorable Chief Justice of India, Health Secretary, Dr. Sareen, my other colleagues from NAMS and Directorate General of Health Services, ladies and gentlemen. Before I start, I was asked for some biodata, which I did not give. I said I live in present, I am the Director General, that's it. So they took the excerpts of what is written on the Directorate General of Health Services website, and that's been stated here. Now, before I go further, it's actually a privilege to address this literal August, despite court judgments which have time and again ruled out that FIRs or police cases cannot be lodged without actual medical negligence being proven. Third estate hasn't helped either, with headlines like so-and-so killed by a doctor. This is time and again, it screams on televisions, it's on papers, which is not really correct. Well, suicide by a gynecologist in Rajasthan was recently a case in point that needs to be seriously looked into. The fact of the matter is that expectations of doctors from doctors, as Dr. Sareen mentioned, need to be realistic. A doctor may not be able to cure or save everyone he or she treats. In fact, there is an age-old saying which says, I treat, he importantly, it will reduce the pressure on practitioners of medicine, which will improve the quality of medical care. Today, decisions are sometimes taken because of fear of law rather than the correctness of the decision itself. That will be benefited. Second small thing I would like to mention in front of Honorable Chief Justice is the relationship between education and law. I will stick to only medical education because that's what I deal with. The instances of people going to courts against conducts and or results of examination, both entrance examination and university examinations, is increasing day after day. There is a need to seriously think about it because it derails the entire process and many more processes related to it which affect the career of individuals, a large number of individuals. Well, on a lighter note, I would like to say that weight of a case and weight of the lawyer may not match at times. And that fact should be given due consideration while accepting these cases. I would end here because I'm keen to listen to words of wisdom from Mr. Rajesh Bhushan, which I am actually really fond of hearing. And also, of course, the man of the moment, Honorable Chief Justice N.V Ramana ji. Thank you.
Thank you, sir. And presiding over the program today, we have Shri Rajesh Bhushan ji. He joined Indian Administrative Service in the year 1987. He has worked as officer on special duty in Ministry of Health and Family Welfare for 3 months, prior to which he was secretary in the Ministry of Rural Development and in Cabinet Secretariat. In his more than 3 decades of public service, both in state government and union government, he has served as an administrator, a policymaker, having held a wide range of assignments in the field of information, education, transport, rural development, and health. During his 2.5 years of Cabinet Secretariat, he gained valuable exposure in assisting the Cabinet Committee on Economic Affairs, the Cabinet Committee on Security, and the main Cabinet. Presently, he is working as the Health Secretary, the Pearls of Wisdom, and guide us through your experience.
The chief guest of today's inaugural NAMS public oration, Honorable Chief Justice of India, Shri Justice N.V Ramana ji, Director General Health Services, President National Academy of Medical Sciences, Secretary National Academy of Medical Sciences, very eminent and distinguished colleagues who are here, ladies and gentlemen. I am not here to deliver a lecture. I am more in the capacity of the hosts welcoming Honorable Chief Justice Ramana to this public oration. But I would like to share with you certain peculiarities which are there in the overall health sector in India, which do lead to certain challenges, which have ethical implications, which have legal implications, which have administrative implications. As we all know that in the Constitution of India, health is a state subject, but over a period of time, ours is a big country, a large country, 137 crore people, and a large number of states, union territories, different in their terrain, different in their socio-economic development. So what we have witnessed over the past few decades, we say inequity in development, it reflects in the development of healthcare infrastructure also. There are certain regions, particularly north of the Vindhyas, where there has been a historical deficit of healthcare infrastructure. And this has led to the union government initiating multiple programs which are popularly called centrally sponsored schemes in the domain of healthcare and healthcare delivery, although it still remains a subject which is to be dealt with by the states. So that has its own challenges in terms of uneven implementation, in terms of conflicts that often arise and the challenge is to resolve those conflicts in a amicable, harmonious manner. So that is one overlying thematic strand that we must keep in mind. The second important thing that I'd like to draw the attention of all the eminent colleagues who have gathered here is the exponential increase in the healthcare delivery system that we have seen in the past decades. Today we have about 13 lakh doctors, mainstream allopathic doctors, registered on the rolls of different state medical councils in the country. We have around 8 lakh Ayush practitioners. We have 600 medical colleges, out of which 350 are owned and operated by either state governments or union governments. We are one of the largest, in fact the second largest after China, generic manufacturers of medicine in the world. Every other child in the world is inoculated using a vaccine manufactured in our country. So this exponential growth of pharmaceutical sector, of healthcare professionals have also created challenges of how the profession would be practiced, how the profession would be regulated, how ethical values within the profession, because we are talking of 13 lakh people and we are not even counting paramedicals. So how those ethical values would be transacted while providing patient care. We should also see, when I say uneven development of health infrastructure, there are huge challenges of deficiencies in infrastructure or health systems. At times, the line between negligence and systemic deficiencies is very thin. So how do we distinguish that both administratively and legally? That's another challenge. Of late, the emergence of new technologies, if we look at last two sessions of Parliament, the Parliament passed Assisted Reproductive Technologies Act. The Parliament also passed a couple of other allied health services regulation act. So these are areas which are emerging where boundaries are not clearly drawn between what is a standard template of care and what is an emerging technology, and how would that emerging technology be actually delivered as treatment. So these were some of the things that I wanted to draw your attention to, because the lecture that Honorable Chief Justice is going to deliver is something which would not only touch upon these various aspects, but would also trigger a productive and mutually fruitful debate within the professional community as well as the health service providers, and that I think is eventually good not only for the profession but also for the country. I take this opportunity to once again welcome the Honorable Chief Justice of India with folded hands, and we hope that his presence here and his insights would immensely benefit us all. Thank you.
Thank you so much, sir. And as I earlier mentioned that the great initiatives of National Academy of Medical Sciences, the latest one are the Task Force on Organ Donation and Transplantation. Organ transplant is the best treatment for end-stage organ failure in diseases like liver cirrhosis, cardiac failure, and chronic kidney diseases, with an increase in non-communicable diseases and alcoholism. The consumption of alcohol in the country is at rise. The need for transplants in individuals who get these end-stage organ failures are increasing. In our country, there is a need for approximately 1,75,000 kidneys and 50,000 liver, heart, and lung transplants. Most of these transplants in our country happen in the private hospitals, which become unaffordable for most people. Today we will be having the release of the task reports, and the other initiative that we are going to talk about is the task force report on venous thromboembolism, which is a clotting in the blood vessels. It is a medical condition that affects many people, especially those at risk, like the people who are bedbound, older patients, older people, people who are obese, prolonged immobility, physical inactivity, and genetic blood conditions are among the main causes. Here, there is perceived gap in the appropriate management and prevention of VTE across the country. In the view of aging population of India, it becomes important that we pay attention to the management and prevention of venous thromboembolism. The chairperson for the task force is Lieutenant General Velu Nair, and the chairperson for the task force on organ donation and transplantation is Professor Y.K. Chawla. I would now request for the release of these two task force reports. Can we have the reports, please, on the stage? And I request the distinguished guests to release the task force report on organ donation and transplantation and the task force report on venous thromboembolism. Put your hands together, please. A huge round of applause for the people who have been associated and worked hard for this task force report. Both these initiatives have been wholeheartedly supported and encouraged by Professor S.K. Sareen, President of NAMS, and Professor Umesh Kapil, Secretary, National Academy of Medical Sciences. Please put your hands together for this successful result of the task force reports. And as it is said, it is a proud moment for all those who have worked in this initiative and those who have supported this initiative wholeheartedly. और कहते हैं कि मेहनत जब सफलता में बदलती है तब हजारों ख्वाहिशें उड़ान भरती है. It is always important to award and reward the people who have undergone any success and who have made their act successful, because it is an inspiration and motivation for all others to work for these successful events. So for felicitation, may I request Dr. Lieutenant General Velu Nair. He is a hematologist, former Director General, Medical Services, Indian Army, Medical Corps, venous thromboembolism. He is the chairperson for this task force. May I request him to come on the stage, please? And I would request the eminent experts, guests, to felicitate Lieutenant General Dr. Velu Nair. For the next felicitation, may I request Dr. Yogesh Chawla to come on the stage. He is former Director, PGI MER Chandigarh, and he is the chairperson for organ donation and transplantation. Please put your hands together. For the next felicitation of the oration, Dr. R.V. Ranjan oration, I would request Dr. Ashish Banerjee to come on the stage. Please give a huge round of applause for Dr. Ashish Banerjee. The next felicitation for Achanta Lakshmipati oration, Dr. Krishnamurthy Jaina. Please come on the stage. The next felicitation For Colonel Sangam Lal Memorial Oration, Dr. Sanjeev Kumar Gupta, FAMS. I would request you to come on the stage, please. Please put your hands together for Dr. Sanjeev Kumar Gupta. It is a great proud moment because these people have worked a lot and succeeded in their task. The next felicitation for Dr. V.R. Khanolkar Oration, Dr. Amit Rawat. For the next oration, felicitation for Dr. Prannath Chotani Oration, I would request Dr. Pragya Dhruv Yadav to come on the stage. I would request Dr. Divya Vohra to come on the stage for Dr. B.K. Anand Oration. Please put your hands together for them. And for Dr. B.K. Anand Oration, we have Dr. Mahendra Kumar Thakur, FAMS. Please come on the stage, sir. And for the oration, Dr. Baldev Singh Oration, the felicitation for Dr. Pradeep Sharma, FAMS. Please come on the stage, sir. Please put your hands together for all those who are getting felicitated. It's a great proud moment for all those who work for their motives and get succeeded. Thank you, sir. Please be seated. And as we have the Chief Justice of India, Justice N.V Ramana with us, I would request him to enlighten us with his words. Previously, he was a judge of Supreme Court of India, Chief Justice of Delhi High Court and Acting Chief Justice of Andhra Pradesh High Court. He has been a president of Andhra Pradesh Judicial Academy. From 1979 to the year 1980, Justice Ramana was a journalist for the Inadu newspaper. He enrolled as an advocate on January 10, 1983. He practiced in High Court of Andhra Pradesh, Central and Andhra Pradesh Administrative Tribunals and Service and Election matters. He also handled a number of constitutional matters, including federal river disputes in the country. He has handled civil, criminal, labor, service and election matters. Administrative Tribunal at Hyderabad, he has worked for that. And he has also functioned as the Additional Advocate General of the state of Andhra Pradesh. Justice Ramana was appointed the 48th Chief Justice by President Ram Nath Kovind on 6th April 2021. Sir, please, I request you to come and enlighten us with your valuable words.
Welfare, Professor Atul Goyal, Director General of Health Service, Dr. Umesh Kapali, Secretary, National Academy of Medical Sciences, respected doctors and professionals, media persons, other distinguished guests, and awardees of eminent doctors who are apologize for late coming. It's I'm sorry I kept waiting. The reason is one of my sister judge house there is a prayer meeting. That's the reason why there is a delay. I'm very sorry for that. And first I want to pay tributes the people, the doctors, medical professions, paramedical staff who sacrificed their lives in this COVID pandemic. I pay my tributes. Now, in the beginning, when I entered into the premises of this NAMS, I remember number of times I visited and met Dr. J.S. Bajaj. He is to be my doctor. He is to, not only doctor, I had a lot of bondage with him because getting appointment with him those days is difficult. He used to see very few patients. And he used to give, I think, every 2 months once, that too with great difficulty. He used to spend almost 2 hours, 3 hours when I met him about my disease, about my medication, and he is only 15-20 minutes. Rest of the time is about discussing a whole lot of issues across the world, starting from astrology, history, politics, whatnot, and memories and jokes, a lot of other things. So I used to enjoy that meetings. So I remembered him. That's what I am asking Dr. Sarin when I came. This is the same place where I used to meet J.S. Bajaj. He is one of the finest and great human beings, apart from doctor. In the beginning, Dr. Saran Saab will mention the Honorable Health Secretary came at 5:40, waited, and that is the power of the Supreme Court. I can say it's not the power of the Supreme Court. I say it is the respect the institution health, and it is the confidence and faith which the institution has earned more than power. So I am very happy in this evening to stand before all of you to share some of the issues which Dr. Saran Saab is always to talk and discuss. In fact, I am hard pressed with time. And to say truth, on the way while coming to the residence to the car, I started correcting my speech, which I have dictated. Some mistakes might have taken place, excuse me for that. But I did my best to put some thoughts. It's a pleasure and privilege to be here in the presence of such distinguished medical professionals. Perhaps you are in the only profession which follows Gandhiji's principle, that is, service to man is service to God. The practice of medicine is the bridge between science and technology and human mind and body. Doctors express this scientific understanding day in and day out through their medical practice. There are very few professions that exist in a constant state of flux in the way the medical profession does. In fact, striving to improve and the care and service it offers. The significance of health of our people is reflected in the emphasis that makers of our constitution have given to the subject. Our courts also have played significant role in realizing these goals and shaping the healthcare policies of our country. The directive principles have placed emphasis on the minutest details of health, nutrition, working conditions, and welfare. In addition to the directive principles, the Constitution in the utilization and adequate health care upon the local bodies. Since there was no explicit mention of right to health under the fundamental right on the part of the government hospital to provide timely medical treatment to a person in need of such treatment results in violation of his right to life guaranteed under Article 21. Towards imbibing and accumulating greater knowledge. The possibilities of growth, both medicine and law, are one of the oldest professions in the world. They arise from basic necessities of a dignified human being existence. People place their faith in lawyers and doctors alike, more than simply intervene at a stage where a patient's life is at risk. They play an active role in prevention of disease, in spreading awareness of best health practices, and are instrumental in improving quality of life in countless ways. In contemporary times, the doctors play multiple roles. They are healthcare providers, caregivers, educators, managers, policymakers, etc. Our recent experience with
taught us the significance of robust health care for all. We have all learned how a health emergency can cripple the entire nation. Health infrastructure and policy cannot be planned only when an emergency arises. It requires careful planning and involves meticulous thought process to manage resources in an efficient and effective manner. Being the primary stakeholders in the healthcare system, doctors are extremely important in framing the roadmap to healthcare in India. The medical expertise, interaction with the patients from varied groups, and the status in the society provides you with a unique position and power to influence the society. Your relationship with your patients provides you with an opportunity to develop a deeper and wider perspective on social issues. Your clinical excellence, professional integrity bestows you with the faith of the public. Admittedly, your profession is a service for humanity, but we also need doctors to assume larger public roles and allow grievances within the system to be aired. As a primary health givers, doctors can play transformational roles in enhancing social well-being. There is a glaring lack of medical practitioners in leadership roles. The need of the hour is to bring. It is a responsibility that must be borne with utmost seriousness. Considering the nature of your service, the doctors are not only individually responsible to the patient. Needs discussion is the growing and unchecked commercialization of our health system. Private hospitals are being opened where profit making is more important than service towards the flight of patients. They are just numbers for them. This trend has also spread monopoly and is deepening the inequities in access to healthcare. I understand that there are many doctors on the boards of various private experiences, and sub-para service has marred the relationship between the doctors and the general public, especially in a country like India, where there is immense disparity in access to health care. Doctors are accountable to the public. Exorbitant medical fees coupled with excessive barriers has made it almost impossible for the poor to get a decent health care. It is primarily the cost of health care that is forcing people to suppress their health care needs and well-being. The heartbreaking fact is that the crucial preventing stage is often lost when people suppress their medical health need. They only approach the doctors when it is unmanageable and has crossed a certain threshold. Another side of lack of accessible health care is giving space to quacks. Quackery begins where awareness ends. Where there is room for myths, there is a room for quackery. Quackery is the biggest disease affecting India. Trained and uncertified doctors, lack of awareness and knowledge, misplaced belief, and sheer inaccessibility has massive ramification on the health of the country, particularly the rural and underprivileged in India. Need of the hour is to bring in a legislation to save people from falling prey to fraudulent practices in the name of treatment. Medical awareness is extremely significant for our society, which is filled with inherent notions and superstitions. Disease prevention and management is even more crucial for the marginalized classes, and lack of good health care will only add to the social and economic stress. Therefore, we need doctors to focus on well-being of the masses that keeps the wheel of our society and economy moving. We need more and more young practitioners to work for universal health coverage and reduce disparity in health care. Undoubtedly, the duty of care is inherent in the medical profession. From the ancient Roman and English laws to the present times, law places clear consequences for willful disregard of one's own duty. It is a phenomenon which has implications from diagnosis to treatment and rehabilitation. Even the smallest error by a physician can have a profound impact on the patient's life. Therefore, it is the doctor's responsibility to use due caution and prevent such events. The existence of a doctor-patient relationship is a prerequisite to impose culpability on the doctor. Since the patient typically has only a limited understanding of the illness and the process of treatment, the medical professional has a larger duty to the patient in fiduciary relationship. Treatment of an individual involves various stakeholders. They have to traverse through doctors, private hospitals, and insurance companies. Through this process, the patient blindly trusts only the doctors. It is doctors' presence and involvement that gives the assurance to patients that have not just consumers. In the landmark decision of Jacob Matthew versus State of Punjab, the Supreme Court of India laid down guidelines in cases of alleged negligence against medical practitioners in India. It is clearly stated that there is a need for protecting doctors from frivolous and or unjust prosecution. Over a period of time, this court has clearly stated that an error of judgment or an accident is not a proof of negligence on the part of a medical professional. He or she would be liable only where this conduct fell below that of the standard of a reasonably competent practitioner in the field. However, these issues need to be adjudicated as per peculiar facts of each case. Doctors ought not to be penalized if best intentions were on display and best efforts were made irrespective of the results. After all, doctors are humans too. I can narrate one incident where one gynecologist once she mentioned to me, the patients are so innocent and the common people believe that doctors are angels and they don't get even diseases. Some patient asked her, "Madam, doctor, you also get diseases." This is the knowledge, this is the standard of people's understanding about the system. So they think doctors are supreme and they don't get diseases also. Now I must come to a topic that I feel strongly about. During the pandemic, I saw various instances where doctors have been threatened, abused, attacked, and shunned. Despite this, they continued working on the front lines. This negative response towards doctors is truly unfortunate. Several false cases are being lodged against upright and hardworking doctors. They need a better and more secure working environment. We must foster an environment where more young people want to become doctors to serve Indian society. This attitude toward doctor is pushing out our best talents abroad. A massive brain drain is taking place where young, talented, and hardworking doctors do not see a future in India. We as a society must change this and incentivize our doctors to stay in India and continue their service and help meet both our medical and social goals. The central and state governments to have a serious responsibility. Many aspiring doctors from small towns and rural areas rely on government for education, support, and employment. But beyond this initial support, the government must look out for their welfare of its doctor and improve their working conditions. The government must think of stronger incentives to make doctors accessible to rural population. And even though I want to discuss about the medical education and the organ donation legislations, now after 27th, after my retirement only, I can discuss those issues. NAMS has nearly 1,000 top medical professions, fellows and about 10,000 members led by Dr. Sarin. What a wealth of wisdom. National health and medical education disease prevention policies should be guided by NAMS. Implore all senior members of NAMS and others and those engaged in medical profession. Your selflessness and resilience or
Yeah.